Yeah. Good morning, everybody. I would like to take this chance to sincerely congratulate the scientific and organizing committee for the great success of this meeting. And I wish the rest of it the very best going forward. And we will start our session with crucial zone in neonatology, where there is a lot of knowledge gaps, and I'm pretty sure that this session will fill all our debates. So we'll start our lecture, which is about exclusive human milk diet, and it's my honor to present Dr. Abbas Al-Amran. He's a consultant neonatologist and head of the pediatric department, deputy medical director in Al-Mana General Hospital in Al-Hassa. Welcome, Dr. Abbas.
Thank you very much. Bismillahir Rahmanir Rahim. Assalamu alaikum jami'an wa rahmatullahi wa barakatuh. Good morning, ladies and gentlemen. I think I would like first to thank the organizing and scientific committee to give me this chance to speak about this hot and very important topic in regard of use of exclusive human milk, only human milk, for feeding infants in the NICU, especially the preterm infants. So as an overview or outline of the lecture, as Professor Alan Locke has said, that breast milk is for babies and cow milk for cows. So this is the overall lecture. And I quoted his pictures from one of his slides. Always he presents this slide showing the possible adverse effects of using cow milk on babies, especially the preterm ones, that as you see a lot of pathology, and that ends with death, possibly. Around 10% of our babies, they are admitted to the NICU for different reasons. And this heterogeneous group of babies differs in their gestational age, birth weight, or pathology, but all of them, they benefit from human milk diet. The benefits of human milk are well known, and not only the benefits, the risk of not feeding the baby exclusively breast milk is also well recognized. And human milk is not only a diet or a nutrition, it's a medicine for the babies, especially the preterm babies. We know currently that human milk benefits the babies in general, but particularly the preterm ones in several areas, mainly the host defense mechanisms, the immune system, development of the immune system, and development of the gastrointestinal tract, as well acts as a special nutrition that is tailored for every baby according to the gestational age and the postnatal age as well. And it has advantageous neurodevelopmental outcomes and has effects also in the long-term benefits, even to adult life. Over the last 3 or even 4 decades, human milk was rediscovered again as one of the key factors in improving the outcome of preterm infants admitted to the NICU, and it became the standard of care actually in the NICU. But unfortunately, the rate of human milk exclusively, or any human milk for NICU graduates, is still low. As I mentioned, it should be the standard of care in the NICU, but unfortunately, randomized control studies cannot be done. They are unethical because you cannot group patients or cohort babies on one group, exclusive breastfeeding, and the other one is formula. That is considered now unethical. But multiple studies done before have demonstrated significant benefits from human milk, which I will show later, for both whether you are using the mother's own milk or donated human milk. Professor Alan Lucas, again here, in 1990 published a large study on 926 multi-center studies, a study on infants who are preterm babies, and they received either mother's milk or formula or both, or donated human milk. And they found out that the NEC rate was, the overall NEC rate was 5.5, and the mortality of 26% on those who developed NEC. But the important thing was noted that confirmed cases of NEC showed 10 times more common in babies who are exclusively formula compared to breast or human milk fed. And those who were on mixed diet, they were three times more common than human milk alone. And this, I need the audiovisual help. My slides are not shown well. But if you can look at the right side, hello, Jamil, it's not, slides are not clear. On the right side, we can see that the human milk compared, it's not, it's there. There you are. It's not. It's not on my computer. It's not on the computer. It's. This is 5 minutes waste, right? بعد الكمبيوتر أدف الكمبيوتر شوية أقول يمكن لو دفيت الكمبيوتر شوية
لا هي بس طفت الكهرباء هي والريستارت just continue ما في مشكلة.
Cannot continue بعدين السلايدز ما واضحة. Yeah, I think better to wait, isn't it? Because نص الشاشة
الكيبل بس يعمل له ريستارت.
Okay, I think we can continue now. Thank you. So as you see here, the open bars on the right side showing the cases of NEC on babies who were fed bovine-based formula compared to the human milk formula. You can see significantly lower incidence of medical, surgical, as well as all NECs and even mortality. In a systemic review and meta-analysis of human milk feeding and morbidity in very low birth weight, this study, which was published last year, showed evidence of clear protective effect of human milk against NEC and possible reduction in late-onset sepsis as well as severe ROP. But in addition, it showed that any human milk is better than none. And the more human milk the preterm infant receives, the better the outcome. And the National Institute of Child Health and Human Development, in their large study, they found out that the risk of sepsis during the first 35 days of life decreased as the amount of human milk increases in preterm babies in the first 14 days. So particularly the protective effects of human milk, there are so many factors contribute in this protective action, but mainly these factors include nutritional, enzymatic, hormonal, direct immunological, immunomodulatory, anti-inflammatory, and antioxidant, as well as growth factors. And one of the important protective effects of human milk on the baby operates through what is called enteromammillary system. I cannot use the pointer, but as you see on the diagram there, that not only antibodies actually pass from the mother's gut through the lymphatics to the circulation of the mother and then excreted in the human milk, even some of the bacteria is modulated, translocated, and migrate to the secretory milk and then goes to the infant's gut and contribute in production of the microbiota of the infant. Skin-to-skin practice also is very good because the baby also will transmit some of the bacteria, commensal bacteria that are nosocomial, and the skin of the baby will be transmitted to the mother, which is going to produce antibodies, which is going to be excreted also in the breast milk in another way of giving protection to the baby. The maximum protection comes from the colostrum, as you would expect. But it continues not only during the neonatal period, but actually it will continue even after discharge. Human milk contains a lot of bacteria, and it harbors bacteria at a concentration of approximately 1,000 cell forming unit or colony forming unit per ml. And the estimated breast fed infant ingest up to 800,000 bacteria per day. It's a lot of bacteria, but to show you how much the breast milk gives protection to the baby. And it is well studied and well shown that babies who are fed human milk will have different normal flora or bacteria in their gut compared to formula-fed infants. And during the first month of life, infants who primarily feed on their mother's own human milk, they will have around 28% of their stool microbes sharing with their mother's own. And as the baby feeds more from the breast milk, also the more sharing in a dose-dependent way. These are some of the bacteria commonly detected in the breast milk. Streptococcus and staphylococcus are the most common species, but bifidobacteria and lactobacilli are also seen in there. There are so many factors that affect the milk microbiota on the mother side. That includes the gestational age, the delivery mode, and the health status of the baby, medication, especially the antibiotics taken by the mother, genetics and the geography location, as well as the diet and the stage of milk, whether it is colostrum or early or preterm or premature or term milk, as well as the amount or type of the human milk oligosaccharides and the amount of immunity related to the microbial or intrabiome. These are all affects the microbiota, whether at the end give the baby protection against the pathogens and give him what we call healthy or useful bacteria or bad bacteria at the end. So not all bacteria are bad. Some are beneficial to the infant and some are bad. And what decides this is human milk can help a lot in promoting the growth of the beneficial bacteria and suppressing the growth of the pathogens. For example, lactobacilli isolated from human milk have been shown to inhibit adhesions and the growth of gastrointestinal pathogens that include Salmonella and Shigella and E. coli. Dysbiosis is the loss of balance between the good bacteria and the pathogenic bacteria, and this can continue not only during the breastfeeding period, but decides the bacterial promotion or bacterial growth in the milk later on. And Packard et al. In 2015, after study of the pathogens, they found out that cessation of breastfeeding rather than induction of solid foods is the major driver for the development of adult microbiota. So microbiota during the infancy can decide the microbiota later in adulthood. And Ding in 2014 found that history of breastfeeding in an infant dictates the bacterial community later on the same principle. Not only actually bacteria, but even viruses. Breast milk can decide the type of bacterial viral presence in the breast milk. It also enhanced the growth and development of the gastrointestinal tract, and human milk was found associated with faster decrease in intestinal permeability and induction of intestinal lactase activity, as well as more rapid gastric emptying, and this will facilitate reaching full feeds in earlier time. Reaching full feeding faster means less IV infusion, less IV insertions, and less side effects of TBN, and decrease the hospital stay and cost. And human milk is considered special nutrition for babies, and it's actually tailored according to the needs of the baby. Preterm milk differs from human full-term milk in many things, but in the contents of nitrogen, protein, total lipids, energy, vitamins, and minerals. As you see in the table, for example, in energy, in a baby receiving 150 ml per kg, preterm one, they will get around 104 calories per kg compared to around 96 for term milk. Not only the gestational ages differ, there are also studies showing different in the sex, according to the sex of the baby. So male breast milk for boys differs from breast milk for girls. And this has been shown in animal as well as in human studies, but results still need to be validated. Further studies are needed. In the long-term neurodevelopmental outcomes, I think by this time, although there's a lot of debate, but there's significant evidence that human milk confers neurodevelopmental advantages. Locus, again, 1998, he studied the long-term neurodevelopmental of a large cohort of preterm infants, and he found higher IQ by 8 points in infants who fed their mothers on milk. Professor Vore also in 2007 found the dose-response relation between the amount of human milk feeding and the neurodevelopmental outcome. And she found out that for each 10 ml per kg per day increase in human milk ingestion over the NICU stay, there are increase in the mental as well as psychomotor and behavior scales of 0.5 to 0.8 points. The long-term effect also has been studied, and it was found that there is a reduction in the risk of cardiovascular and bone disease, also the blood pressure and lipid ratio. And human milk also contains a lot of antioxidants and can prevent or mediate many diseases related to oxygen-free radicals. These are some of the human milk bioactive components, but breast milk is considered a tissue because it contains stem cells and other cells, prophylactics and prebiotics, human milk fat globules, and the newly discovered extracellular vesicles that share in the immune development also, and around 1,000 components more, and probably a lot more that we don't know. But there are problems and challenges of using human milk in the NICU. Human milk can have problems during expression or storage and feeding, especially contamination with organism, because GBS and MRSA have been implicated in morbidity as well as mortality in preterm infants fed contaminated milk. But we have to weigh the benefits from using human milk and the risk of having problems if there is a possibility of contamination. The contraindication, absolute contraindications are the following: human immune deficiency disease, HIV disease, especially in developed countries, but in less developed or in developing countries like in Africa, they allow breastfeeding for HIV positive mothers. Human T lymphotropic virus type 1 and type 2, and active tuberculosis is also contraindicated. There are cases where you can temporarily ask mother to pump and dump, like in varicella zoster, measles, and herpes. Although infants of women with hepatitis B virus can transmit the virus, but they can be allowed to breastfeed after receiving the vaccination and the immunoglobulin. Transmission of hepatitis C through the breastfeeding has not been documented, so they can still breastfeed. CMV, freezing the milk, may decrease CMV but does not reliably eliminate it, and it can produce a sepsis-like illness, especially in very preterm infants. And again, you need to weigh the balance between the benefits of human milk and the possibility of developing infection in a CMV positive mother. Now, also the challenges include that some extreme preterm babies, the human milk might not be enough in the term of the requirements of protein and minerals. So you need to fortify it with products that includes protein, calcium, as well as phosphorus and calories. And the recommendation now that you use human-based human milk fortifier, not anymore cow milk. And the liquid non-acidified human milk fortifier is currently recommended. So it's recommended that human milk is the standard and the only feed for the baby, whether it is the mother's own milk or donated human milk. And this is where the idea of human milk banks came. And human milk banks was established in last century, maybe for more than 70, 80 years now. The American Academy established its first formal guidelines in 1993, and the Human Milk Banking Association of North America in 1985 put strict procedures for donations, donor screening, milk processing, storage, as well as shipping. The World Health Assembly endorsed the global strategy for infant and young child feeding, which recommends bank donor milk as the second best, only after the mother's own milk. And the American Academy of Pediatrics and the World Association of Perinatal Medicine state that bank donor milk should be promoted as a standard component of healthcare for preterm infants. I'm quoting these because these are the pioneers, authorities in infant feeding. Does processing the milk change its quality? In general, nutritional components may be altered somewhat, but Holder pasteurization does not seem to influence the growth of preterm infants, especially the low birth weight. Holder pasteurization is they heat the milk up to 62.5 degrees centigrade for 30 minutes. There are other methods, but this is the most common method, and it's reliably eliminates all functional white blood cells and bacteria and inactivates HIV, HTLV, CMV, as well as other viruses that it decreases activity significantly. But the human oligosaccharides as well as the essential fatty acids are usually not affected by pasteurization. The exclusive human milk diet means that you feed the babies, especially the preterm in the NICU and after discharge, only breast milk, and only breast milk either comes from the mother or donated human milk. And with the introduction of human-based human milk fortifier, that the babies only receive human milk plus human milk fortifier, and preliminary studies so far showed decrease in the incidence of NEC and death in these babies. So how do we establish maternal milk supply? How do we get as much as or half of this amount in mother, so you can see how much this mother produces? If the mother understands that each drop of her milk will benefit the baby and act as a medicine, she is going to produce. So it's our responsibility as neonatologists as well as the responsibility of obstetricians, team work between obstetrics and the NICU team, including the nurses and health educators and lactation consultants, all work together antenatally and postnatally to help the mother to produce milk. But early and frequent as well as effective breastfeeding or expression are the keys for successful milk production.
3 minutes.
Do we need a consent for before starting formula? I think we will reach to this stage considering the side effects of feeding a baby formula and not feeding the baby, and the disadvantage of not feeding breast milk mothers. We have a great responsibility in explaining to the mothers the disadvantage that the baby might have. If you give me 2 minutes more, I will handle this topic, which is really very difficult, but I think we have to handle it. What is the situation in the Islamic countries in regard of the milk banking? If you see on the map, in our country, the rate of breast milk feeding at 1 year is very much almost zero. But at 6 months, we have around 24%. So overall, the rate of breast milk is very low, unfortunately. And The problem with breast milk banking in the Islamic countries is the concept of milk kinship, al-ukhuwa min al-rada'a. And because sharing of milk in the form of wet nurse creates kinships, and thus marriage prohibition between the family of the donor and the recipient. And this is based on the phrase of Al-Quran Al-Kareem in Surah An-Nisa, ayah number 23. قال تعالى بسم الله الرحمن الرحيم حرمت عليكم أمهاتكم وبناتكم وأخواتكم وعماتكم وخالاتكم وبنات الأخ وبنات الأخت وأمهاتكم اللاتي أرضعنكم وأخواتكم من الرضاعة. In English, forbidden for you in marriage your mothers and your daughters and sisters and your foster mothers who have suckled you and their daughters. So on this basis, the milk banking is not developing in the Islamic countries, but there are reports on trials. This was early report in 2002 that came from Kuwait, where a baby was born at 29 weeks, extreme low birth weight, and the mother was advised to express her milk, and she produced a lot of milk, and there were twins and other triplets in the unit, and because she understood the importance of breast milk, she volunteered to give them her milk. She was producing around 900 cc of milk per day. So the team discussed this issue with the other families, and they agreed. So she donated the milk to the others, and all the 6 babies were fed from one mother. So this case was reported as some modified form of breast milk banking. But a detailed review was written by Dr. Muhammad Ghali, who is expert in Islamic law and ethics. And I'm quoting his words. And he said that in Islamic law, under specific conditions, so there are conditions, breastfeeding institutes a type of permanent non-biogenic kinship relation which bar marriage. And a boy breastfed by a woman other than his mother will be prohibited from marrying this woman and her daughters. And the mother also cannot marry to this child or his children. And this is based, as I said, on Quranic phrases as well as prophetic references. And there are 3 pillars of breastfeeding kinship. That is the wet nurse, al-marda, and the milk, and the baby. So in the wet nurse, there are 2 issues here. Identity of the wet nurse. So the question comes, does suckling from more than one wet nurse institute milk kinship with them all? The Muslim jurists opined that if more than one wet mother breastfeed for one baby, if they are giving the same amount of milk, then kinship will be produced to all. But if one mother giving more milk than the others, only the mother who gave a lot of milk will be considered as there will be kinship with her. But if these wet nurses or mothers cannot be identified, either because they are too many to record, or because their names are not known, like what happened in milk banking, then there is no kinship, because the other party with whom kinship would be instituted is unknown. So those who say halal milk banking, they take this into consideration. The milk has to reach the stomach. There is no way to consider kinship if the milk is not going to the stomach. I'm saying this because if you read in the literature and the history of Islamic laws, some have used oral as well as through the nose and even rectally, but only the milk that reach the stomach is considered. And the majority of jurists did not differentiate between the milk getting into the stomach through suckling directly from the breast or through cups or bottles or tubes, or even through the nose given directly. However, according to the Shiite school and minority among the Sunni jurists, only suckling directly from the breast directly institutes kinship. And this is رأي الشيخ القرضاوي كذلك.
1 minute more, Dr. Abbas.
Concerning the amount of milk, come to the amount of milk, the majority of jurists, the Hanafi, the Maliki, and opinion of Hanbali, opine that little milk institute kinship similar to large amount of milk. But other jurists, including the Shafi'i and Hanbali, stipulated that the nursling must drink at least 5 times, 5 sessions. And according to the Shiite group of jurists, more than 10 times or sessions, each of which is separate from the other. Otherwise, suckling will not be considered as kinship. And the baby, the third one, the baby has to be less than 2 years. Once the baby is 2 years and above, kinship will not be there. But the fatwa from the International Islamic Fiqh in 1985 stated that establishing of milk banks should be prohibited in the Muslim world. But in 2004, the European Council for Fatwa said that making use of milk banks in case of need does not raise religious problems and does not institute kinship and par marriage. In Turkey, they have made a questionnaire to 400 Muslim jurists, and their opinion was that only limited donors for limited mothers cannot be open banking. And this is the same also in Malaysia. But in Iran, they established the first breast milk bank in 2016, full breast milk banking. The British Council for the Muslim Council of Britain also, they have issued a resolution that say that there should be no doubt or no problem because they can trace the donors for 30 years backward. So those who wants to trace it, it's there. So in summary and conclusion, the human milk in health care settings, especially the NICU, is considered medicine. Human milk has a cost-effective intervention to reduce disease burden during hospitalization and to promote childhood and adult health. Human milk is the feeding of choice for preterm infants. And current recommendations are the use of mother's own milk when available, with appropriately screened and pasteurized donor human milk as the next best choice. And human milk banking is left for discussion still. Thank you for supporting breastfeeding.
Thanks, Dr. Abbas, for this comprehensive talk. And now it is my pleasure to introduce the second speaker for this session, Dr. Imad Mohammed Khadawardi. He's Associate Professor of Pediatrics at Al Faisal University, Consultant Neonatologist, Deputy Chairman, Department of Pediatric, King Faisal Special Health and Research Center, Board Member of Saudi Neonatology Society. He's gonna talk about nutritional supplement in preterm infants. Welcome, Dr. Ahmed.
Thank you, Dr. Jamil. Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everyone. I want to thank the scientific committee for inviting me to talk at our prestigious 19 Neonatology conference, and I'm very glad to be here with you today. Our talk is a continuation, of course. Nutrition and neonatology does not start always by breastfeeding, it's the source. So nothing will substitute the breast milk for our small babies.
The birth of an extreme preterm infant usually is a nutritional emergency. It's emergency everywhere. If we have 24, 25 weekers, emergency in the unit, emergency for the on-call team, emergency for the caregiver, and it's a nutritional emergencies. With advancement in the care of the preterm infants, the goal have expanded from thinking do they will survive or not, to how to mimic the fetal growth and how to think now about optimizing their neurodevelopmental outcome later on. Too many studies now focusing on optimizing the nutrition, thinking about the outcomes. We start seeing results talking about outcome for many big trial occur at age of 7 and 8 years, and most of it link the current practice and the old practice to the outcome. The management challenge for this infant relate to, unfortunately, we don't have an appropriate tool to monitor growth, and Dr. Hindi will talk about that later on. Availability of nutritional products designed to support them. Even though if we said we have preterm formula, still that preterm formula is developed from a term formula. And I agree with Dr. Umran's breast milk is #1. We cannot consider cow milk for the preterm babies. And the morbidity that complicate the ability to deliver optimal nutrition. Sometimes our fear from establishing the feed, risk of neck, abdominal distension, ventilations, inexpert staff, all of these will lead to delay establishment of the nutrition in this small group. The incidence of growth faltering is inversely related to the gestational age. So if you have a smaller baby, of course, the nutritional emergency and the growth faltering will be more compared with bigger one. An independent risk factor for growth effect, including male gender. Of course, all of us knows males is more suspected to have worse outcome in the ICU compared with female. Length of hospitalization, length of ventilatory support, bronchopulmonary dysplasia, necrotizing enterocolitis, and the exposure to steroids during the hospital course. So what is our nutritional goal? The nutritional goal for premature infant is to achieve the rate of growth and nutrient accretion similar to those achieved by infant of similar gestation age inside the utero. I know it's difficult, but there is too many studies now reported giving us a hint about how much nutrient required, what is the growth target, how much rate of minerals, vitamins will be accreted at this time for the fetus inside the utero. In a study of 1,660 premature infant with birth weight below 1,500 grams, the discharge, at time of discharge, most infant born below 29 weeks had reached the median birth weight had not reached the median birth weight of the reference fetus at the same post-menstrual age. So still, even though with the advancement in the care, we still are not doing good at time of discharge. Still, we have poor nutrition. Still, we have very low weight compared with bears who delivered at term. To match fetal growth, an infant born at 24 weeks gestation needs to double the weight by 30 weeks. And to be more than 5 times its birth weight by 40 weeks. It's too much jump. And this phenomenal growth demands a much higher intake of energy, protein, and other nutrients than is needed by infant born at later gestation or at term. Extremely preterm infants are born with low stores of key nutrients such as iron, zinc, calcium, phosphorus, vitamins, and with little or no subcutaneous fat and glycogen stores. And all of these will lead to complications that are known for all of us. Nutritional management infant has changed considerably. If you remember, I'm still, maybe it's not time to take a survey or a quick, but I'm still like some units still starting amino acid by 0.5 in the 2nd or 3rd day of life. And then the increment will be on the next day by 0.5. And they will reach 3.5 to 4 by the end of the 1st week. Same apply for lipid. Some units still delaying starting lipids up to 3rd day, 4th day of life, some of them after the 1st week even. And this is all will contribute to nutritional emergency, loss of retentions, nitrogen retentions, lost for essential fatty acid required for this time at time of growth. In a survey of practice in Europe and US showed that only 38% of neonatal unit gave the recommended protein intake on the day of birth, and only 40% of neonatal units give lipid by day 3. So the strategy involved initiating early parenteral and enteral nutrition, especially initiation of amino acid infusions, providing about 3 grams per kilo per day within hours of birth. Lipid emulsion of 0.5 to 1 gram per kilo per day within 24 to 30 hours of birth, and of course establishing the trophic feed as soon as possible. First week protein and energy intake are associated with 18-month development outcome in very preterm infant. And in this graph, you see we have the smooth 10th and 50th percentile reference fetal growth curve, and then at time of delivery, and in this example it's what, close to 25 weeks, the first initiation of nutrition, which is the early aggressive, considering the proteins and the trophic feed, which led the curve to go up slightly, and then after reaching the full feed, the human milk fortifier or the preterm formula, which will give another jump to the growth curve. Finally, it will be completed by the post-discharge nutrition. But still, even with this support, still we are not doing good at nutritional wise and to having the good birth at time of discharge. So what is the metabolic effect of early aggressive nutrition? Usually our fear from starting TBN that will be reflected on high renal functions, the metabolic acidosis, but an increase in the BUN, which observed after the start of TBN, is related mainly to increase of the intake of amino acids after we rule out any other effect. And it's not necessary to reduce the amount of amino acid if there is no hyperammonemia or metabolic acidosis. Early TBN also with proteins will minimize the occurrence of hyperglycemia, hyperkalemia, and decrease in the growth regulating factors like insulin growth factors. So what about trophic feeding? So enteral feeding in very low birth weight infant is often delayed for several days after birth because of respiratory compromise and fear of neck. Delayed enteral feeding usually diminish the functional adaptation of the gastrointestinal tract and the feeding intolerance later on, and it will be difficult to help in our course. Preferable to begin feeding with breast milk, of course, as we said earlier, and if not available, donor milk or premature infant formula may be used. The safety of early trophic feeds was supported by meta-analysis, which conclude that early initiation of trophic feeds was not associated with increased risk of neck in very low birth weight infant. Fortification of human milk. So unfortified human breast milk may not meet the recommended nutritional needs of growth in preterm infant. And there is no definite guidelines for when to start human milk fortifier. So during my search in the literature, I found too many references, everyone talking about their own practice. So some units fortify as soon as a total intake reach 25 ml per day. And some fortify when amount reach 100 ml per kg per day. And other units fortify when a full volume of feeding established. In our unit in King Faisal, usually, in King Faisal Specialist Hospital, usually we fortify when the patient reach full feed. We start by half fortification and then we go the next day to full fortifications. So preterm infant fed with HMF have been reported to gain weight at or slightly greater than the intrauterine rate and show increased length and head circumference at a rate similar to intrauterine rate. So it's help in the growth of those babies. And the addition of HMF to human milk increased the concentration of energy, proteins, minerals, calcium, phosphorus, and increased the rate of weight gain and the linear growth. Most studies use bovine-derived HMF and report no adverse effect on feeding tolerance or risk of neck compared with unfortified human milk. But as Dr. Amran said in his previous lectures, now there is an HMF derived from the donor milk, and we have also a liquid HMF, which is only licensed to be used so far in US. It's not available in our market. And the difference between the powder HMF and the liquid HMF is the amount of the proteins. And of course, the easy mix for the solute. In this table, you can see the difference between the unfortified human milk and the fortified human milk compared with the preterm formula. And the first graph is the recommended, or the first line is the recommended intake. So for unfortified human milk, the calorie, as all of us know, 20 per ounce, calcium 37, phosphorus, and vitamin D. Adding fortification increased the calorie to 24 and increased the amount of calcium, significantly jumped to around 200 with increase in the phosphorus and increase in the vitamin D. And this will be close to the amount delivered in the Britain formula. So adding HMF after establishing the full feed will really help the bone of our preterm infant, will enrich their growth, will help them in gaining weights and achieving the expectation. Preterm infant formula, so it's usually a protein-enriched formula, 2 grams per 100 mils, and have higher energy of 24 or 30. Between them, we have also a 27 kilocal formula. The higher energy formula has increased fat and lower carbohydrate content to reduce the increased osmolarity. It's recommended that the high energy formula not to be used as ready-to-feed formula early on when we establish the feed in the very low birth weight infant, and they can be switched later after establishing full feeds and monitoring their weight gain. In large preterm infant study, low-calcityl demonstrate higher cognitive and motor scores at 18 months, corrected age, and higher verbal IQ and lower rate of cerebral palsy at 8 years of age in preterm infant, feds preterm versus term formula. And magnetic resonance imaging study showed that infant fed preterm formula had significantly larger caudate volume. So belief regarding minimizing the risk of neck, as we said, will lead to delayed of introducing or advancing of the enteral feed. So use of a standardized feeding protocol to minimize clinical practice variability will help in that. It will minimize the rate of neck and promote improved neurodevelopmental outcome later on. A systemic review demonstrated that slow feeding advancement does not reduce the incidence of neck, but prolong the time to achieve full enteral feeding. And we have the feeding protocol established and published by the Saudi Neonatal Society, I think 6 to 8 years ago, by the Guidelines Committee. It's still, most of the units in the kingdom are using it. I think the protocol needs to be updated, but it's a good start if you don't have a feeding protocol in your unit, and it's available in the society website. Total parenteral nutrition. So the TBN was first used in newborn infant almost 50 years ago. And since then, it has proven to be valuable, life-saving in preterm infants who are unable to tolerate sufficient enteral feeds to meet their nutritional needs. The limitation and toxicities of TBN have become increasingly recognized. As a result, the practice of the TBN continues to evolve. Every day in every conference that we attend, we are hearing new advances about TBN, in addition to hear about new complications of the TBN. So we have two types of TBN. Early phase TBN, which started as soon as possible after birth, usually within a few hours. Some hospitals, they have it ready, depending on their rate of admissions. So you can open the fridge and you can get a ready or starter TBN. Some hospitals, they have a deal that with the clinical pharmacist, they will prepare it for them after delivery. Its primary goal is to prevent excessive catabolism. It usually contains dextrose, amino acid, and calcium. And intravenous lipid can be included or added on the first or second day of life. It will come later we'll talk about the intravenous lipid, but now too many studies recommended starting intravenous lipid in the first day of life when we start the TBN with a small dose. It's provided as little as 30 to 40 kilocalories per kg per day in the beginning, and this should be increased starting from the next day of life. Full TBN, usually introduced to meet the entire nutritional needs of the infant. It must contain a wide range of essential nutrients as sufficient protein and energy to support the growth. And it should contain 85 to 95 calories per kg per day of energy to allow normal growth rate. Usually this will be established at the 5th or 6th day of life. For the protein intake, preterm infants have limited energy stores at birth and must catabolize protein to meet their energy requirement. A preterm neonate without a supply of protein may have an endogenous protein loss of 0.5 to 1 gram per kg per day. And because of that, protein should provide 10 to 15 of total energy intake. And we should, of course, start the protein early. At least 3 to 3.5 gram per kg is needed to promote protein accretion and prevent negative nitrogen balance. Several controlled studies have shown the efficiency and safety of amino acid when initiated shortly after birth or within the first 24 hours at a rate of 2 to 3 gram per kg per day. Current recommendation suggests 2 to 3 gram per kg per day of amino acid on the first day of life. That can be increasing later on to 4 gram per kg in the first week of life. Early amino acid can stimulate endogenous insulin secretions, improve glucose tolerance, prevent hyperglycemia, hyperkalemia, and decrease the need for insulin to manage significant or rebound hyperglycemia. In this graph, you can see this data was, it's a courtesy of Neonatal Data Analysis Unit in the Imperial College. And it's give you a hint about the last 4 years used of TBN. And you can see in the purple, the last one there, in the purple bar, which represent 2013, there is an increased number of units that start using TBN within the first day of life compared with 2010. And I think now we'll see it more and more since we start knowing that proteins is very necessary and it can help and manage most of the complication usually we see in the first few days of life. For example, hyperkalemia, hyperglycemia, and the change in the other electrolytes. Carbohydrates, so glucose is the main energy source and the most widely used carbohydrate in the TBN. And dextrose should provide 30 to 35 of daily caloric needs. Glucose infusion should match endogenous glucose production of 6 to 8 milligrams per kg per minute. And excessive glucose infusion has many adverse effects, including increased energy expenditure, increased oxygen consumption, and of course, osmotic diuresis. Routine use of insulin may result in modest reduction of hyperglycemia, reported to improve early weight gain, but at the cost of increased frequency and severity of hypoglycemia. Bertzel et al. Studied 389 very low birth weight infants who were randomly assigned to receive either standard of care for glycemic control or a parenteral nutrition of 20% dextrose with 0.05 insulin infusions. The study found increased episode of hypoglycemia and increased mortality at 28 days of life in the infant receiving insulin. Because of that, the current evidence does not support the routine use of insulin in preterm infant to help in the growth. Lipids are a major source of energy and should provide 25 to 40% of non-protein parenteral nutrition calorie. Source of essential fatty acids and long-chain polyunsaturated fatty acid is needed for those small infants in their first or second day of life. Lipid tolerance is optimal with a 20% preparation. So we have 10% and 20% preparation, and the 20% showed to be optimal because of lower phospholipid to triglyceride ratio. And the osmolality of the emulsion is same as the plasma, so it's safely to administer through the peripheral or central line. Commercial lipid emulsion are based on soybean oil, which is not suited for prolonged use more than 2 weeks in parenteral nutrition, and it was linked that it may cause cholestasis and liver dysfunction. Fish oil containing lipid emulsion known as omevegan, and lipid emulsions containing medium-chain triglyceride, olive, and fish oils known as SMOF-lipid are most recent development in lipid emulsions. In our hospital, we are using the SMOF lipids. I'm sure 2 years ago there was a lectures and a conference addressing using of different kind of lipids here in this conference. And when the cases that we expose the infant to SMOF lipids is when those usually develop cholestasis. So if we have a protocol, and it's proven to be safe. It helps in reducing the amount of the bilirubin and the dysfunction of the liver, of course, while building the enteral feed. The absolute treatment for cholestatic liver disease related to TBN is to push for your enteral feed and get rid of the TBN. But so far, our experience with the SMOF is good in the hospital. Early introduction of lipids. The American Academy of Pediatrics recommended early initiation of lipids on first day or second day of life at a low dose of 0.5 to 1. And early introduction is safe and well tolerated in very low birth weight infant and associated with weight gain and could improve early nutritional support. So what about calcium and phosphorus? Low birth weight infant have significantly lower calcium and phosphorus store compared with term. Estimated daily enteral calcium and phosphorus requirement in preterm infant are 120 to 230 and 60 to 140 for both respectively. Providing calcium and phosphorus in TBN, it's really challenging because of the limited solubility, and calcium to phosphorus ratio of 1.7 to 1 is the optimal for bone mineralization. Magnesium has a high accretion rate in utero and should be supplemented to preterm infant at a rate between 8 to 15 milligram per kg per day. Vitamin D, so the level of 25 hydroxy vitamin D more than 80 is considered sufficient, and a vitamin D intake of 800 to 1500 international unit is necessary to increase that level to around 75. Centrator reported that calcium absorption in preterm infant increased from 50 to close to 70% when supplemented with 1,200 international unit a day. And in the United States, the American Academy of Pediatrics recommend vitamin D intake between 200 to 400 international unit when they reach full feed and before discharge. And in Europe, guidelines suggest a higher vitamin D intake of 800 to 1,000 international unit. Of course, during the period of adaptation after delivery, the very low birth infant does not necessarily require any electrolyte, including sodium, potassium, and chloride. Frequent monitoring of these electrolytes is essential in this infant during this period and to determine when to add it. A sodium intake of 2 to 3 millimole per kg per day is allowed the growth and maintain the appropriate serum sodium. Same for potassium, an intake of 2 to 3 millimole per kg is recommended. Preterm infants have low body store of fat and water-soluble vitamins at birth, and vitamins and minerals should be provided with all parenteral nutrition regimen, including TBN. Trace elements are essential for normal enzymatic function, and insufficient intake will retard the growth and cause anemia. Standard formulation of trace elements include zinc, copper, selenium, manganese, chromium, and carnitine. Of course, a certain addition of this trace elements with underlying cases of liver failure and renal failure that we should be careful and cautious in adding those minerals to the TBN. Iron preterm with low birth weight infant at high risk of iron deficiency, and iron is necessary for brain development, deficiency associated with poor neurodevelopmental outcome. Excessive iron supplementation, on the other hand, may increase the risk of infection, cause poor growth, and interact with absorption of other minerals. Iron is not routinely added to the TBN for preterm infant, and recent studies suggested that initiation of iron supplementation at age of 2 weeks compared with 6 to 8 weeks leads to reduced need for blood transfusion in very low birth weight infant. European Society of Pediatric and Gastroenterologists recommend iron intake of 2 to 3 milligram per kg per day with the birth weight below 1,800 gram. WHO recommend 2 to 4 milligram per kg per day, and the American Academy of Pediatrics recommended 2 milligram per kg at the start point at age of 1 to 2 months for all low birth weight infants. And these doses can be adjusted later on to the maximum of 6 based on the response and the degree of anemia. So, in the previous presentation, we talked about the very low birth weight infant that most of the studies actually done. We knew about their needs. We knew about their some complications. We know briefly about some of the standard intervention required. But for the moderate to late preterm infant, usually we know little bit. It's not yet covered a lot in the literatures. Even though sometimes in our daily practice we don't know what to do with them. If we have a 35-weeker who is 2 kilos, usually we leave them with the mother. and in the same time, they still consider preterm. So this is a dilemma. Should we feed them? Should we start TBN? Is dextrose 10% enough for them while we are building the feed? Or starting TBN is required? So those usually account for more than 80% of preterm infants worldwide, totaling about 13 million. And these infants, therefore, constitute a much higher proportion of health care. Moderate to late preterm have nutritional challenge after birth that are similar to those born extremely preterm. At 34 weeks gestation, the overall brain weight is 65% of the brain weight at 40 weeks. So early nutrition to support brain growth is critical in this infant. There are no data to support supplement, as we said, with formula milk early after birth or whether to wait for the breast milk, and same apply for the 10%. And this area of study, and I think it's still there is a gap in knowledge, and this area need to be covered by more studies. Post-discharge stage, although there have been improvement of the growth due to better general neonatal care, achieving post-discharge catch-up growth, especially during critical period between 40 and 48 weeks post-menstrual age, is vital for optimal neurodevelopmental outcome. And two major strategies can help in that. First one is the multi-nutrient fortification of breast milk, and the second is the enriched formula or the preterm formula after discharge. Some of the hospitals recommend discharging babies who are receiving expressed breast milk on fortification for a period up to 6 months at home, and they will teach the mother how to fortify. Some of the hospitals will recommend, if the mom feeding the child directly from the breast, to express at least 2 to 3 feed a day and adding HMF to promote and push the growth and to cover the nutrient requirement for those infants. Of course, using of the post-discharge formula or the enriched formula is recommended. This formula is really high on calorie, high on protein, 2.1 gram in 100 ml, and variably enriched with minerals, vitamins, trace elements as compared with standard term formula. And there was more rapid and more complete catch-up growth, improved cognitive outcome in infants who were fed the nutrient-enriched post-discharge formula to 6-month corrected age. Before we finish, just a quick touch. It was covered briefly by Dr. Al-Umran, gender, smell, and taste effect. So although girls and boys have long been known to grow differently, little attention has been paid to the postnatal to improve outcome after preterm birth by feeding girls and boys differently. And in the studies that reviewed, there is nothing said for boys they will do that and for girls they will do that. Even though we know the requirement is different and they will grow actually different. Nevertheless, there is limited evidence that breast milk composition varies according to the gender of the offspring, lending biological acceptability to the proposal that nutritional need might be different in girls and boys. Smell and taste. So most of our babies usually fed by NG tube till they reach for the full feed, and then we start introducing the oral feed. Smell and taste are important for efficient metabolism as they activate the cephalic phase response and release of appetite hormone in the saliva. Preterm infants receive milk via gastric tube with no opportunity for smell or taste, and the data indicate that provision of smell and taste before gastric tube feeds can decrease the time to reach full enteral feed and can promote the full suckling feed. So the take-home message, preterm birth is a nutritional emergency. The goals of nutritional management of premature infant are to mimic intrauterine rate of growth and nutrition accretion and to optimize the neurodevelopmental outcome rather than focusing on growth alone. Protein intake in the preterm infant during early life may be beneficial effect on the growth and neurodevelopmental outcome later on. Breast milk is the optimal food for all infants, including extremely preterm infant, and fortification should be used to meet the needs of extremely preterm infant and is necessary to avoid growth faltering. Complete parenteral nutrition, including intravenous lipid emulsion, should be delivered to extremely preterm infant on the day of birth. Bone health is a critically important concern for premature infant, and calcium and phosphorus are critical components for bone structural integrity and growth. A standardizing feeding protocol and use of human milk are important steps in prevention of necrotizing enterocolitis. Lastly, preterm infants are often significantly underweight at time of hospital discharge and remain at increased risk of the nutritional risk later on. Thank you very much.
Thank you very much, Dr. Imad, for this pointed speech. And now we will proceed for the last lecture for this session, which is about the monitoring of postnatal growth. Will be presented by Dr. Muhammad Al-Hindi. He's a consultant and neonatologist in King Abdulaziz Medical City, assistant professor in King Saud University of Health Science in Jeddah, and a master in clinical epidemiology at University of Calgary. Welcome, Dr. Muhammad.
Hi, Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Thank you for the scientific committee for inviting me to present a topic about monitoring growth of preterm infant in NICU. The previous two speakers, actually, they introduced a very comprehensive approach for the nutrition in the NICU. Now we end up by, okay, how we monitor the growth for these babies in the NICU. When we going to talk to you about this topic, I might challenge some views to wake you up before breakfast. So I might challenge some views that you might see that some stuff that we're been doing routinely, and then it's being challenged here. So hopefully we'll arrange a little bit of questions. So there is no international, as we said by Dr. Ahmad, there is no international consensus regarding how growth of preterm infants should be monitored, and what are the constitute of the ideal pattern of growth, and what is the ideal growth after a period after they reach their term gestation. This is consensus. However, the American Academy of Pediatrics endorsed the WHO and the Interchange 21 initiative that monitoring postnatal growth of preterm infant, present, and future. This was published in 2016. And it was mentioned in that in this consensus, the recommendation that there's a systematic review done resulting in 61 longitudinal reference discharges were identified. All these growth charts had limitation in the quality of gestation age estimation, anthropometric measures, and feeding regimens, and how morbidities are being described. And their conclusion was to support the International Fetal and Newborn Growth Consortium for the 21st Century Project, which I will introduce to you now. This was actually being produced in the past meeting, in the SPR meeting in Boston 2016. If you go in the same the systematic review, this graph, actually I liked it so much. If you look at, this is the history of graph charts. It does not point here, but anyhow, I'm trying to do the pointer, but if you can see, it started all in 1971 by our famous textbook editors, the Nelson, and then followed by the 76, and then Fenton started introducing her charts in 2003. Then the UK, with the help of WHO, introduced their charts in 2009, and eventually 2013 is the Fenton chart based on systematic reviews done. And now it's been, this Fenton, Tanis Fenton, I had the pleasure to work with her, and we took her permission. So the Saudi Neonatology Society, when we published the feeding guidelines for preterm infants, we used her growth chart as a reference chart for monitoring growth in preterm infants. And you can see that in the Saudi Neonatology Society website. And we believe that this needs to be updated now with the new evidence of data. This was published, our Saudi Neonatology Society Feeding Preterm Infants and Monitoring Growth was published in 2010. Now, these are the Fenton charts references and with the validation. And these are the graphs that been introduced by Fenton. And it shows that you can follow preterm infants as low as 23 weeks, up to 50 weeks preterm post-menstrual age. And many units are being using this chart, including our unit. Now, this is a challenging point. Should a preterm infant grow like a fetus? So we know that preterm will deliver before their time, and we anticipate that, okay, we need to give him nutrition to let him grow as a fetus. Now, this concept was not supported by any data, and practice is seldom attained. I would argue, like in the biggest network, the Vermont-Oxford network, over more than 1,500 preterm infants, whether they are moderate preterm or very low or very preterm infants, less than 32 weeks. They found that even 90% of them did not grow like a fetus. So based on this data actually came from American Academy Guidelines, 1977. So that also tells you that not always Americans are the best advisors, okay? So general statement that the growth of preterm infant should allow that of the normal human fetus. And it is stuck then since that time. Nobody challenged that view. However, lately now, this is being challenged. Now it's focused only on early postnatal period up to 40 weeks. That's another limitation. An attempt to force preterm infants to gain weight as if they are in utero, this will lead to what? Definitely you're not able to follow that. Rarely, like maybe 5% of your preterm infants population will attain the growth that you want or you desire. You want to see it very nicely in the graph drawn. So this will lead to what is labeled as postnatal growth failure and severe growth failure. If postnatal growth failure, if you reach the growth less than 10th centile, and severe growth failure 3rd percentile, and you feel inside sad and unhappy that your unit is not doing well. For very preterm infant, at the 32-week fed on infant human milk, have an accelerated head circumference growth birth until discharge, even during the poor neonatal growth. So that's another point that you have to look into. Accelerated growth early in life may be in a higher risk of metabolic and cardiovascular problems later in life. So please don't rush, don't try to achieve that for letting the baby to grow as in utero. So preterm infant, this statement is very important. Preterm infants is not in any nutritional, metabolic, or physiologic sense a fetus and should not be managed such in clinical practice. Now, the growth charts. We'll challenge another point of using the growth chart. What we are using now is what we call a reference growth chart. Reference growth charts are based on data routinely collected, and they are decades earlier, where the neonatal care was not so that advanced, and no standardization of quality and control of the measures, and they are descriptive. They describe how subjects have grown in a particular time and place. While what we are introducing here, what's being introduced now, is what we call a standard growth chart, which is a prescriptive, or what you call strict standards, rigorous anthropometric measures collected prospectively and used to define how subject should grow under optimal condition according to their clinical status and degree of maturation. This is, of course, is very challenging in preterm infants. Again, reference growth chart depends on time and place, depend on where they are collected. Is it an advanced unit or is it in a developing country unit? And demographics affect the assessment, and there are poor tools for research and comparison for nutritional status, as I showed initially in the systematic review. While in the standard growth chart, it's universal, independent of time and place, and is used to assess all fetuses and newborns, irrespective of their background, demographic background, socioeconomic status, and level of health care, and it's ideal for harmonization for research protocols, systematic reviews and meta-analysis, and international comparison of nutritional status. So, what is the ideal standard for preterm infants? So the postnatal growth standard for preterm infant postnatal follow-up study, what we call now the Intergrowth 21 First Century Project, and these are the multiple authors and being supported by the Melinda and Gates Foundation. It is a multi-center, population-based study done between 2009 and 2014 in 8 locations worldwide, and the countries and the states are being selected randomly, and they are listed here. The participant eligible for the fetal growth longitudinal study are components of this project. Those women are in any ethnic origin. They have started their antenatal care before the 14 weeks gestation and based on reliable menstrual days and confirmatory ultrasound, and most of their health and nutritional needs are being met and not exposed to major environmental hazards during pregnancy like smoking. Now, when I'm mentioning only the highlights, if you see the protocol of the study, it's like 200 pages of the study that's having very strict criteria of who are the women who enter the study to consider the ideal mother and also the ideal baby. A singleton preterm baby was born to the follow-up mothers, born 26 and above weeker, and later on they included even the 23, 24 weekers, and were eligible for enrollment. And they put a very comprehensive exclusion criteria of those who develop these stuff like PVL, severe IVH, severe surgical PDA, severe retinopathy. They were excluded from the study. So they are trying to reach to the ideal preterm infant. Now, intergrowth is a multiple growth measurements, not only to neonatal, it's also for pediatric and also for women health. It includes pregnancy data, includes fetal size in early pregnancy, and also includes the symphysis fundal height, the fetal growth, and gestational weight gain, newborn size for preterm infants. This is for the very preterm infants, those who are less than 32 weeks, and for the newborns, the regular newborn size, postnatal growth of preterm infants, and the study goes on. They included more than 20,000 subjects. So the weight and the length and head circumference are measured rigorously in a standard. If they have published their protocol very in a strict way, and also they showed videos. They teach those who take the anthropometric measure, and they show them videos and teach them and make sure that so we don't have center-to-center variation. Within 12 hours of birth, and after 2 weeks, and the first 2 months, and every 4 weeks until a postnatal age of 8 months, and measurements are made for at least 5 months after due date, with some babies actually being discharged. And all babies should follow up at a minimum of 64 postnatal menstrual weeks, which is around 6 months of age. Feeding practices. Thank God, Dr. Ramad and of course Dr. Amran, they mentioned the ideal feeding practices. Promotion of clinical feeding practices were standardized across all sites. So all the sites has the standard feeding practices, and it is based on finding of a systematic review. Basically, what they did: breastfeeding and bottle feeding of express breast milk were only allowed. Okay. And the recommended starting volume was 80 ml per kg per day and increased up to 160 to 180 ml per kg per day. And feeding were allowed via NGT tube if required. And for babies born less than 32 weeks, they allowed the trophic feeds, and they strictly followed the duration of exclusive breastfeeding up to 6 months of life. They supplemented vitamin K, iron, and vitamin I as per standard recommendations. And they use also human milk fortifiers as per described by Dr. Ahmed. And they ended up by 200 preterm infants out of 4,166, which are around 5% of the healthy mother. If you have a healthy mother, they didn't have a risk factor, there is a risk of always 5% of developing preterm infants. And when you compare the parameters here, there are no difference. There is no difference between preterm and term infants. What they ended up by are growth charts, which are, this is for the females, and the first one is the weight with the postnatal age, and the other ones are the head circumference and the length. This is for the females in pink, and this is the blue in for the males. Now, if you look at, let's take the middle line here, the blue line. Okay, this is the 50th percentile. The 50th percentile of the intergrowth 21st century preterm postnatal weight standard for both sexes combined. Okay, and this is the actual fetal. This is the actual fetal. The red line in the middle is the actual fetal growth, and you can clearly see that once the baby is born, he's not a fetus anymore. He's a preterm infant that has a different trajectory of growth, and you can see that in the 50th percentile that the middle blue and the red are really different. So what about the very preterm infant, less than 32 weeks? The team received many requests for very preterm size at birth as chart for clinical practice and research, and they published their supplement in 2016. Most pregnancies have some risk factor. Of course, you cannot get a birth for preterm infant without at least one risk factor. So they accepted some risk factors, except some what I'm going to describe. Most pregnancies have some risk factor, and the prescriptive or the strict standards were difficult to construct. But anyhow, the original sample were supplemented by included neonates from the same intergrowth population and born to mother with some risk factors, except smoking and severe obesity, and the babies did not have congenital malformation, and the ultrasound during pregnancy did not show fetal growth restriction. And this is what they produced. They produced as low as 24 weeks growth charts that these are for the boys, and these are for the girls. And when they combined the charts together for extreme preterm and low preterm, they found that the extreme preterm, or the very preterm infants have more towards like a longitudinal line, while the moderate and late preterm have more smoothing, curved lines. And this is mainly because of the sample size. Now, when they combined the two graphs of the interchange 21 and the Fenton chart, they found that actually Fenton chart is actually estimating the weights that the baby should be, and this again emphasized that we should treat these babies differently regarding the weight. And by the way, at the ends of the curve, at the end when they are 6 months of age, these curves they go smoothly with the WHO curves up to 2 years of age. So in conclusion, monitoring growth of preterm infant under standard graph is the best tool so far available, and further updates with larger sample size to smoothing the curves for the very preterm infants are warranted, although it's difficult. And it's time for the SNS now to update its guidelines for breeding preterm infants and augment it with standard rather than reference growth monitoring graphs. I would thank all the audience for bearing with me, and I will see you any questions.
Thanks, Dr. Mohammed, for this excellent presentation. May I ask the speakers to come to the stage for, we'll take 2 to 3 questions because we are running behind the time. Any question?
Hello, Assalamu alaikum. I'm Dr. Jubaira Abouat from Abha Maternity and Children Hospital. Our unit is 51-bed capacity. First of all, I want to thank the organizing committee for a very successful event. As health practitioner, we have to believe that exclusive breastfeeding is the best for all babies, especially for preterms. My question is, donor milk allowed in the kingdom, in the health facilities? And if so, do we need to get consent for it? Addressed to Dr. Abbas.
As human milk banking is not allowed so far, but donation is allowed if mother will donate for another baby, if it is known and registered, and both families will agree, it's allowed.
So consent, we still need to get consent from them?
Yes, sure. Both they need to agree because they will consider the future kinship relation.
And it goes with the question, do we need to screen the donor before giving to them the milk?
Yeah, it's better to be screened, sure.
Okay,
to make sure there are no
May I add,
contraindications.
Yeah, may I add my practice here? What I do actually, my first thing is the mother-owned milk. If the mother doesn't have enough milk or she's sick for whatever reason, I always encourage the parents to call for murdi'a, or what we call wet nurse, which is the standard. The problem what I face when I talk about the family like this, they start laughing, okay, especially in the cities. And still I go ahead and explain to them the importance of the breast human milk. So donation is allowed, as actually encouraged by the families to, if they don't have enough breast milk for whatever reason, to look for a wet nurse by themselves. And usually the antenatal screens done here are enough for screening. They will screen for the HIV, hepatitis, and etc. So we encourage that, and we encourage family agreements. Once the family, she can actually bring the other mother, and she said, okay, this is the mother who is going to give the breast milk. This is so totally encouraged in my practice.
Dr. Saleh.
Thank you very much. Actually, I have 2 points. One is about the SNS feeding guidelines. And thank you, Ahmad, for mentioning this. We need really to review it, and thanks for Dr. Mohammed for raising this issue. I think in any guidelines, there is a limited time for them, like 3 to 5 years. Should be at least updated, not to completely review, but at least to be updated. And I agree that we have to really go over the many protocols that developed by the SNS. One of them is the feeding protocol, which is very extensive. I remember I was actually the chairman, or the chairman of the committee at that time, and it took us like almost 2 years, to complete it. Wasn't really easy. So this is a reminder for Dr. Al-Nimri to really go over it and review it and see things that should be changed. The second point, and I'm sure that you heard about it, which is the processed human milk. And now it's available. I think it should really come to Saudi Arabia. This has been discussed at the level of the Islamic scholars, and they don't think that it is a problem, to use it in our units. I think the society also should come from the society, that they recommend it to use the processed human milk instead of the formula that we usually use for our babies. Thank you.
Thank you. So, Dr. Ahmad, what do you think of the priority for updating our feeding protocol for the volume we will introduce, like fast advancement of the feeding in terms of 35 to 40 mL per kg per day?
Well, for the current protocol, I think we're still using it, and I'm sure most of the units in the country, they are using it. And I visited many units in the periphery, and I was surprised, they are using the feeding guidelines established by the society. Even those hospitals, they are not using it. They were really happy to adopt and follow. I will not say the protocol is not proper right now to be used. Still, there is no big change in the literatures, and the effort which was placed by the group, as Dr. Saleh mentioned, to establish this protocol is really appreciated. It's not easy to put the guidelines and protocols. Maybe we need to look a bit about the rate of the increment, and especially for the very low birth weight infants. Maybe we need to add emphasis about the HMF used, including the new addition in the markets. But this discuss, and as a board member, I think in our last meeting, Dr. Nimr is not here, but Dr. Hafzi and the groups, we discussed reviewing most of the protocols, and we are in the process to form a committee within the board to go over the existing protocol and start working on more new protocols that can help the nations. And this is maybe, I will take the opportunity to ask those who are really interested in joining the protocols is just to approach or email Dr. Nimri, because the groups need to formulate 6 or 7 people cannot cover all protocols. I know there is an effort established in the Ministry of Health to have with the protocol guidelines, and that's one thing we can get benefit from in the society.
I think you need also to incorporate the use of human milk in the protocol and to emphasize again.
Other questions, comments? Okay, thank you very much. So,
okay, just a few announcements, if you allow me, before break. Now, on behalf of the President of SNS and Deputy and other board members, I would like to congratulate you for the attendance and for a lot of lectures and very beneficial lectures yesterday and today. Still, we have some lecture very interesting today. First announcement about the certificate. You will go to the website. It's written on the front of the booklet at the end, and then you do the feedback. You will get the proof of certificate. This is very important for us to improve, inshallah, in next meetings. Second announcement about the scanning of the badge. Please just make sure that you scan it in the entrance and the end of each session. Last announcement about the Saudi Neonatology Society. We like to remind all people to register or to renew their registration in the information desk in the front. It will help us a lot to serve the neonatology in the kingdom. And there is a voucher they will issue for who will register as a gift, like who register or renew in the intercontinental they can use during Ramadan for sahur or fatur. Thank you for attendance. And I think the break will take 15 minutes for the break, then we'll come for a second session. Thank you.
جي you come down please جي
في بريك ما بين السيشن هذا.
ما في مشكلة يا دكتور.
أغي
start the second session today about neonatal nursing care. Our first speaker, Khulud Al-Alani. She is registered nurse, neonatal ICU experience, coordinator, general nursing orientation, nursing education department, King Abdulaziz Medical City, Jeddah. She will talk about delivery room management and resuscitation, nursing perspective. Welcome, Dr. Khulud.
Assalamu alaikum. Good morning, everyone. Thank you so much for inviting me out here today. As I'm going to be talking about the delivery room management, stabilizing neonates. So I'm going to be focusing more on the nurses' roles and responsibilities. Okay. All right, so all of us here today are healthcare providers. We're a mix of nurses, physicians, consultants, and RT, respiratory therapists. So during the resuscitation, we're all working together with one goal. That goal is to ensure the survival of this newborn infant, not just the survival, but as well as helping him have a better quality of life, at least minimize the morbidities and disabilities. Do you agree? Okay. So the objectives today, I'm just going to go back and talk about the delivery room management and what we do in resuscitation, and then I'm going to mainly emphasize on the nurse's role and responsibility during the resuscitation, and then how we prepare the delivery room and the golden hour. So we can't mention resuscitation without actually talking about the golden hour. So the golden hour starts the minute the baby is delivered, and it's the medical treatments that it's actually a series of medical treatments and interventions that happen within the 60-minute time frame, which is crucial for the survival of the infant, the newborn. Okay, so in preparation of the golden hours, we're going to have the antenatal counseling, delivery room assessment and monitoring, and then the team pre-briefing. This is preparation for the golden hour, and then during the golden hour, we're going to talk about the delay cord clamping, the temperature regulation, respiratory management, circulation, and then the developmental supportive care. So optimized care within a 60-minute time frame. After that, hands off and eyes on, giving a chance for the baby to then recover from all the interventions that we have done. So again, the nurse's role, starting from the antenatal care, the counseling to ensure the education was done and the counseling was done, then receiving all of this information to better assess and monitor the mother during the delivery and labor. After that, picking up the red flags and signs which will then be communicated to the obstetrician, neonatology, and ICU that there is something going on. After that, assembling the team, and now the team is ready for the delivery. So this should be a standardized and organized approach from the nursing and the physician and the entire team altogether. So I'm going to stress about the antenatal counseling. It was actually stressed as well in the latest 7th edition in NRP. So it's really important for us to talk to the family, to the mother and the father together regarding the situation of the delivery, what to expect, the resuscitation or not, the risk that they are in, and counsel them to ease and create a better trusting relationship. So the nurse's role in this point is to make sure that this actually happens, help to remind the obstetrician and the neonatology in case that, during the chaos they might be a little bit distracted. And then initially there should be a communication between the obstetrician and the neonatology before entering the mother. So that way they will have an established goal, and then to avoid the confliction or the disagreement. So after that, close monitoring of the mother during labor. So it's important for us to do a team pre-briefing prior to the delivery, where assemble the team, contact the neonatology, contact the NICU, and preparing the equipment, identifying the team leader, and assigning the roles and responsibilities to each. So I'm going to show you just a brief video on how this is actually should happen. It is working.
Okay, so we have a 26-weeker that's getting set up in the case room. Do we have the transition checklist for infants born less than 33 weeks ready? Yeah, right here. Okay, perfect. Okay, so I have the history here. Okay. I can go call NICU and INCN to let them know.
Oh, the video.
26-weeker. Okay, and I'm going to check the airway and CPAP supplies. Hey.
So it's pretty much the team getting together, identifying each other, talking about the history.
You guys are going through the checklist? Yes.
Going through the standardized checklist.
Assemble the peripheral IV supplies. I'm just getting the bed set up with the warmer. So I notified the neonatologist. He should be here right away. Was there an antenatal
So
consult?
notifying the NICU physician and the NICU team.
I think we'll start at
Checking
+7.
the equipment. So we're just going to see how the pre-briefing actually looks like, where now the team is all assembled and they're going to identify the risks,
kind of identify everyone, and then
the history of the mother, and identify each other, assembling the roles.
Practitioner today. I'm Monica, research nurse 2. I'm Lindsay,
So introductions are made.
Remember, we got started there.
Who's the nurse? Who is the RT? Who is the physician?
And so you have the history? I do, yes. Okay, so we have, mom is 32-year-old.
So making sure the 4 initial questions are made and the history of the mother is covered.
We're doing an elective section for maternal PIH that has been uncontrolled. Steroids have been given 2 doses 2 days ago. Meg sulfate was given yesterday. Babe has no fetal distress.
Are you already talked to the pediatrician? He's going to do a behavioral plan.
Oh, okay. Sounds good. So,
sorry. Okay, so being prepared for resuscitation is initial step for an effective resuscitation.
Okay, so we have a 26-weeker that's getting set up in the case room. Do we have...
Okay, so delivery and preparation, we should always remember the 10 key behavior skills. During the resuscitation is important as well to maintain professional behavior, to know the contact information that who we're going to call during the resuscitation, when to call them, effective communication, delegation of the work optimally, allocating the attention wisely. And then from the nurse's role as well is to prepare the equipment using our standardized equipment checklist from our NIP guidelines to ensure that each and every equipment is checked for functionality, availability, and the settings as well. So each one of your team members should be an NRP certified currently, and not just like she's done it for, because every few years I think we're updating our guidelines, so they should be a valid NRP provider. They should have the knowledge, the skills, to know what we're looking for, to know what we're expecting. Everyone should know what they should do. Following our algorithm, our targeted probe saturation, all of these things they should be aware of it. They should have the knowledge and the skill of it. So we talked lately a lot about the importance of delayed cord clamping and the benefits that they have. So yesterday in Dr. Jabara's workshop, we mentioned, we actually saw how to do it on a term baby and a preterm baby. But the main point of this, that it should be discussed prior to the delivery. There should be a discussion between the neonatology team and the obstetrician team prior to the delivery for who's going to be doing what, how long they're going to be doing it, 30 seconds, 60 seconds, and there should also be someone timing this to ensure that we're doing it on the exact timing. And I want to stress that initial steps can be done while the baby is on the mom's either CS or normal delivery. So I'm just going to show you a small video on how it can be done on a preterm with a CS delivery. Let me just see if that. So it's a 25 preterm infant or C-section. It should actually be in a plastic wrap and not drying. But the cord is still intact, and the initial steps are starting, drying, stimulating actually, and suctioning. The baby should be wrapped in a plastic bag, not in a towel and dried. So I know sometimes people get anxious when it's preterm, as they're worried that they might not have enough time. But then again, yani, the baby should have the infant should be at least stable enough for us to do the delayed cord clamping. So the effect and that it has on the delayed cord clamping is good for the hemodynamic stabilizing, as we mentioned earlier this week, as well as in decreasing the need for blood transfusion and other benefits that we've talked about throughout this conference. But then there's also a contraindication that if the placenta itself is not healthy, it's not intact, that we shouldn't do delayed cord clamping because there's no benefit to it. Okay? So maintaining thermal regulation is highly important, and it's a major role that the nurses play during the resuscitation. So again, following our NRP equipment checklist. Okay, stand here. So if it's a preterm baby less than 32 weeker, we should first start with adjusting the room temperature to a 23 to 25 degree, and then preheating the radiant warmer, the towels. If it's a preterm, make sure that we have a plastic bag available, thermal mattress, temperature sensor, and then skin to skin, initiating skin to skin actually for a healthy term baby, or stabilized preterm babies, very effective for the mother, for the baby and the mother actually. It helps with the thermal regulation, and then it increases the bonding between the mom and the baby. So, maintaining a thermal regulation is a normal body temperature between a 36.5 and a 37.5. So the mechanism of heat loss and gain is through these four mechanisms: either conduction, where the touching of a hot or cold surface. So this is where the thermal mattress and the preheated blanket would come in. And then there's the convection, where the draft, so this is where the temperature regulation usually comes in. Evaporation, the insensible water heat loss, so this is where applying the plastic bag on the preterm comes in, and then the radiation through the radiant warmer. So these are the four mechanisms that the baby can either gain heat or loses heat. Why are we so concerned of hyperthermia? Hyperthermia is when the body temperature goes below 36.5, because it actually increases respiratory distress and oxygen consumption, decreases cardiac output, increases peripheral vascular resistance, increases metabolic breakdown, as we mentioned in hypoglycemia, and then hyperbilirubinemia. On the other hand, we should also be concerned about hyperthermia when the body temperature increases more than 37.5. So we're taking more than one precaution to maintain thermal regulation, but if the resuscitation is expected to last more than 10 minutes, we should consider putting the temperature probe just to ensure that the baby's temperature is not going into hypothermia, right? So we're using, again, a combination of more thermal measures. We have the temperature mattress, we have the baby on a plastic wrap, we have the cap, and we have the radiant warmer. So applying the temperature probe can help us regulate the temperature to avoid hyperthermia. In the respiratory management, again, following our checklist to make sure that every equipment is available and functioning at the time of resuscitation. So usually in some cases there's a respiratory therapist as part of the team, but in some situation the respiratory therapist is not available, so the nurse has to ensure what is the equipment that she needs to have ready in regards to the gestational age, if it's a preterm, if it's a term, what blade should be used, what size ETTs, making sure that there's a targeted pre-ductal SBO chart, and then making sure the settings are done appropriately, as well as functionality of each device should be tested prior to the resuscitation. Okay. So we stressed a lot about initiating CPAP if the baby is immediately after birth, if the baby is spontaneously breathing with a good heart rate above 100 beats per minute. And it's even shown that it's safe and effective for an extreme low birth weight infant, preterm. But we should also consider that if the heart rate is less than 100, and the baby is not spontaneously breathing, that we should initiate effective PPV. We also stressed about surfactant administration. So this should be actually prepared if you know that the gestational age is going to be less than 30 weeks. The nurse should ensure that she has a surfactant vial ready during while she's preparing for the equipment, because if the baby is stable enough after CPAP, we can do either the Ensure technique or the LISA technique to administer the surfactant as soon as possible. But if the baby is not stable, then we should consider using this later on. So again, the nurse's role in this is to make sure she has the vial ready, the surfactant vial, then assisting with the intubation, making sure the equipment are ready, and helping the physician there while he's doing the intubation. Then there's a consideration of avoiding suctioning post-administration, monitor closely for adverse reaction after administration of surfactant. Another thing we should look at is oxygen therapy. So using a pulse oximeter and oxygen blend to maintain oxygen saturation within a target range, and then starting the initial oxygen at 21% ppv for a term baby. For a preterm baby, we can start with 30% oxygen. So our role, of course, is to as soon as the baby is in, to connect the pulse oximeter probe on the right hand, make sure that it's fixed prior to connecting it to the machine itself, and then adjusting the FiO2 accordingly, and monitor the oxygen saturation according to the targeted range, and then try to avoid hyperoxygenation as much as possible. So ECG lids, according to our guidelines, it's first suggested to put in the ECG lids, but then later on when we get into the heart rate, we go below 60 and we're starting the compression, is advised to actually connect the ECG lids. So I read a study recently that says, why can't we just apply the ECG lids earlier, since we know that our assessments throughout the resuscitation is heart rate, saturation, and respiration. So the argument was made if we actually put this as a priority, will it actually cause confusion or delay during the process of intubation, during the process of the resuscitation? So I believe, early intervention, early assessment can also help us detect what our next course of action will be. So moving on into IV access. So if we're going to need an IV access, we have to make sure that there's a team ready with the epinephrine. There's a nurse who's assigned for the medication. She should know the dosage. She should have the medication ready and how to actually prepare them. And then making sure that there's someone also preparing the UVC set and try to maintain it as sterile as possible. So our job is to assist in the UVC insertion, preparing the medication accordingly, and then the fixation of the UVC at that time. If there's difficulty during the UVC, we should also make sure that there is an intraosseous device available and ready to be used in case of emergency. So documentation is usually the most experienced or expert nurse who's usually handling the documentation. So the documenter usually sits in charge of keeping track of time. When the baby is delivered, and then they're going to start by when the actual resuscitation started, giving cues to the team leader, 1 minute past, 2 minute past, what's the saturation, what's the heart rate, and then I think it's like an extra pair of eyes for the team leader, that she's there supporting him and guiding him as well. So she's in charge of maintaining the situation and flow and keeping the team leader updated, making sure that she has to complete the entire form in a concise and thorough way, summarizing the resuscitation, and then when and who to call for help if needed. So in an extensive resuscitation, there are some precautions that we need to look at, because sometimes it gets overlooked during the resuscitation with the adrenaline rush that we would have, and then the excitement, and sometimes the resuscitation is not flowing as the way we want it to. So we should think of hyperoxygenation, so making sure that we're adjusting the oxygen frequently. The pressure while we're giving PPV and CPAP, making sure that the pressure settings are not going too high, that we're not giving aggressive PPV. And then gentle handling. Again, I said during the resuscitation we can get excited and we can get frustrated, and handling the baby might get a little more aggressive than we're used to. So for instance, during the stimulation, you're trying to try and stimulate the baby, but you might get overexcited and you're rubbing the baby too hard, and you're shaking the baby a little harder than usual, or just trying to dry the baby harder than needed. So always think about gentle handling. Even when you're doing the PPV, holding positioning the baby, opening the mouth, and using the mask in a hard, harsh way can also cause harm and injury for the baby. During compression, I know the term push hard, push fast doesn't work here. It's not applicable for our newborns, as long as we just hit the 1/3 of the depth, and just enough for us to give us an effective compression. To avoid also injuries and rib fractures. During intubation is where mostly it will cause more injury for the infant, is because the misuse of the laryngoscope, or actually you're getting frustrated that you can't see the vocal cords and you pull and pull harder. So there's a lot of injuries that we notice on the preterm. So just again remember about gentle handling. Also infusion, rapid infusion, the UVC during the resuscitation. So always think about gentle handling during the resuscitation. So moving on to developmental care, developmental supportive care. So after all of the resuscitation that we went through, we put the baby in through a lot of pain and stress. So once the baby is stabilized, once we're ensured that he is hemodynamically stable, he's breathing fine, now it's time for us to transport him to the NICU. I'm not going to talk too much about the care that we do in the NICU. I just want to stress about considering the pain and stress that we put the infant through, and how we can create a more calmer environment in the NICU for our preterms. So we should consider the sound control, minimizing loud voices in the NICU or around the baby, the alarm settings around them, the ventilator, the monitors, and then the light control covering the incubator, just providing a calm and quiet environment for the baby to recuperate after the resuscitation. Positioning the baby in a way that he's comfortable, swaddling, using the nest, and minimal handling is also very important. I know it's an admission baby and we want to do everything we can, and we just, let's do this test and let's do this, and we get excited and we want to make sure everything is covered, but we should also consider that the baby needs to rest. He's been through so much pain and he's going through so much stress. So we just minimal handling, try to do things at once and give him time for the baby to rest. So we talked about involving the parents antenatally. We're talking about giving them instructions and guiding them and having them establish a goal together in the care of the baby. So we should also, it's also fair for us to include them afterwards in the care of the baby in the NICU. So we're going to talk about a family-centered care, which is very important to have the family included in the care of their newborn, starting with, even if it's just a gentle touch, for the mom, it makes a big difference for her to touch her infant for the first time, knowing that he's gone through a lot of pain through the resuscitation and that he's extreme low birth weight or extreme preterm, that she won't be able to carry him or feed him for a long time. So making sure at the beginning that, you know, hand hygiene, wearing the proper PPE, and then having them involved in the care, either nappy changing or OGT feeding, skin-to-skin kangaroo care, training the baby with the bottle feed, and then stressing on the importance of express breast milk, how to storage them, what to bring in, what's the benefits of using breast milk.
3 minutes.
At the end, I just want to stress about the mock code and simulation. It's very important to keep your team up to date and practicing. So practice makes perfect. Conducting these simulations and conducting these practice monthly or scheduled, not just during the NRP, like every 2 years for renewal, but I'm talking about frequent ones, to have the team, first of all, break that fear of attending a resuscitation, and then have them practice more and feel more comfortable. So when a resuscitation happens, everybody knows what to do and how to do things at the right time, even all the way down to documentation. So it's highly advised for us to do frequent simulations for in our departments, delivery room, emergency room, and the nursery. So at the end, I just want to remind you about our goal and about this infant. So we're all working together with one goal to achieve one goal. Okay, we're all working on with the same goal for this to survive, for this infant, just not to survive, but to ensure a quality of life. Thank you.
It's my pleasure to introduce the second speaker, Salman Najjar. She's a nurse clinician in ICU nurse and working in King Faisal Specialty Hospital and Research Center in Jeddah. She is a Canadian certified nurse educator, and she is CBHQ certified. She was going to deliver a lecture about the neonatal skin care.
Good morning, ladies and gentlemen. Thank you to the organizing and scientific committee for inviting me to participate in this valuable conference. The neonatal skin care is of great importance to the neonatal ICU team, and in particular to the neonatal nurses who are providing daily bedside care to the hospitalized neonates. The practice of neonatal skin care is a broad topic with one major goal to achieve, that is the prevention of neonatal skin harm causing injuries to the neonatal hospitalized neonates and further adding to their morbidities. My objectives will be covering the clinical implications of neonatal skin care practices, the nurse's role in applying evidence-based prevention strategies in achieving zero skin harm, and what is the staff and organization responsibilities towards the nursing neonatal skin care. The birth of a newborn represents a sudden transition from a warm, fluid-filled intrauterine environment to a cooler, dry external environment. The skin of the newborn is subjected to a process of adaptation to the extrauterine environment, which requires special care. The care that needs to be provided to maintain the skin integrity of the newborn must be present from the very first moment of its birth. However, maintaining the skin integrity of the hospitalized neonates is difficult because of the vulnerability, the acuity, and the highly invasive interventions and therapies they receive in the NICU. For many years, neonatal skin integrity is an important clinical concern and presents a challenge to the whole healthcare team in the neonatal ICU, and especially to the neonatal nurses who have the biggest responsibility in providing skin care for the full-term newborn, healthy premature infants, and the extreme premature infants. The survival of extreme premature infants did improve since 1970s, and this is due to the advances in the neonatal intensive care. However, the preterm infants are at higher risk for acquiring skin injury, and this is due to their fragile and immature skin structures, in addition to their highly dependence on equipment and medical devices which are required for their management and monitoring in the NICU. And naming from these devices like the central lines, intravenous catheters, mechanical ventilators, non-invasive ventilation like nasal CPAP, temperature probe, ECG monitoring, and saturation monitoring. Research on neonatal skin care is limited, but has been growing in the recent years. However, since 2001, two nursing organizations, the Associations of Women's Health Obstetrics and Neonatal Nurses and the National Association of Neonatal Nurses, published the first edition of Neonatal Skin Care Evidence-Based Clinical Practice Guideline, which included current practice and research in the neonatal skin care, aiming for changes in practice to improve the neonatal skin condition, as well as to increase the knowledge of the neonatal nurses at the bedside. The fourth edition of this clinical practice guideline was recently published in 2018. It's very important for the neonatal nurses to understand the normal structure and physiology of the neonatal skin, and in particular what is the difference between the premature and term skin versus the adult skin. The stratum corneum, which is the top layer of the neonatal skin, plays an important role as a skin barrier function of the neonatal skin by preventing the insensible water loss, prevention from evaporative heat losses, and protection from invasion of microorganisms, protection from the invasion of allergen, and also protection from absorption of toxins. The stratum corneum, the integrity of the stratum corneum is directly related to the gestational age of birth, meaning to say the lower the gestational age, the lower the stratum corneum function. The stratum corneum is non-existent at 23 weeks of gestational age. Fluid layers develops at 26 weeks of gestation, with term maturity reached between 34 to 35 weeks of gestation, and full-term thickness reached at 40 weeks of gestational age. So, the nature of the neonatal skin of the premature infant is underdeveloped and lacking the skin barrier function as compared to the term neonatal skin. Meaning to say that with the premature skin, it increase in the permeability of the skin, will leading to more increase in the evaporative heat losses, will lead to hypothermia, increase in the transepidermal water losses, will lead to electrolyte imbalances and dehydration. There would be a risk of infection due to the invasion of microorganisms. There would be a risk of absorption of toxins from application of topical products, as well as the risk of dermatitis, which is caused by irritation. This is in addition that there is a weak cohesion between the epidermis and dermis skin layers will predispose for more mechanical trauma. So all of this will create or will pose a challenge for maintaining the skin integrity of the premature neonates, which will acquire more skin injuries in terms of pressure injury, epidermal stripping, and contact dermatitis. This is in addition that there are certain practices that the neonatal nurses perform as part of neonatal skin care, and this might pose a potential to cause harm to the skin of the hospitalized neonates, and naming for that the perineal care, bathing, the application and removal of medical adhesives, the application of antiseptic solutions, as well as some monitoring devices which can cause harm to the skin, as well as the positioning of the infant on certain medical devices. So all infants who are in the NICU neonatal intensive care unit are more at risk for skin injuries, and these are acquired hospital injuries. There are commonly adverse events in the neonatal ICU for the hospitalized neonates. Studies reported that more than 70% of skin injuries are due to the use of medical devices on the neonatal population, which are needed for their care. In a recent systematic reviews, it revealed where it stated that the most risk factors to acquire skin injuries in the hospitalized neonates are due to the lower gestational age, lower the birth weight, and the use of medical devices. This is in addition to the length of use of the medical device, as well as increase in the length of stay will impact the skin injury in the hospitalized neonates. And this will add more further burden to the responsibility of the neonatal nurses in the prevention of the skin injury, because the gestational age and the birth weight are non-modifiable risk factors. So the authors recommend for more studies to identify modifiable risk factors for the management of skin injury, as well as to have a consistent skin injury classifications which is applicable to the neonates, since the current classification of skin injuries are derived from the National Pressure Ulcer Advisory Panel, which is more for adult injury, validated adult injury system. So, all the skin areas of the hospitalized neonates are prone for skin injuries due to the use of medical devices. So they are prone for pressure injuries, and this is labeled as medical device-related pressure injuries. So the devices, as I've said, it inclusive of non-invasive ventilation from nasal CPAP, nasal cannula, IV tubing, arm boards, blood pressure cuffs, nasogastric, orogastric tubes, EEG leads, gastrostomy, jejunostomy tubes, saturation probe, temperature probe, ET tube, tracheostomy, cables, central lines, and ID bands. All of these will put the neonatal infant in the NICU for risk for acquiring medical device-related pressure injuries. The other types of pressure injury, which is related to immobility, due to the condition of the patient, and usually the pressure injuries are located in the earlobe and the occipital part of the head of the neonate, and this is due to their large disproportional head. The prevalence reported for pressure injuries or HAPIs into the neonatal ICU is between 9 to 43.1% of pressure injuries in the NICU, as well as the incidence rate between 0.49 and 1.5 per 1,000 patient days. These HAPIs, they are called, referred to hospital-acquired pressure injuries, and usually they are directly reflecting the quality of nursing care at the bedside. So the nurses will not be happy if her patient had acquired HAPI. 90% of those pressure injuries are occurring in the premature infants are due to the medical device-related pressure injury. From those, 50% of pressure injuries are directly related to the use of nasal CPAP ventilatory support. The injuries caused from those injuries are referred to mucosal pressure injuries because they affect the nasal internal lining of the nerves. In the literature, especially for the neonatal population, there are limited evidence regarding the treatment and prevention for the nasal injuries caused from the nasal CPAP. However, certain interventions or strategies being documented in the literature to help in the prevention to acquire nasal injuries. From those are very important to choose the correct fitting size of the head, mask, and prongs. It's advisable to rotate the device between the mask and prong. Very important to do the frequent assessment under the device. It should not be left for one day, at least every 4 hours, to lift the device, check the skin integrity of the septum and the internal nerves, and do the massage if the patient is tolerating. It's very important also to apply skin adhesive barrier. The role of the adhesive barrier, it's not to prevent from the pressure-induced device, but rather to prevent further excoriation of the skin. And The device, it should be applied snugly fit, meaning to say there should be 2 millimeter space between the oxygen interface and the septal, nasal septum. And oftentimes we see that the nurses or the respiratory therapists thinking that the baby will benefit more from pressing the device to the septal. And this is wrong. It should be only snugly fit. Otherwise, with the more pressure, you are inducing pressure injuries. In the neonatal population, it has been noticed that there is no clinical assessment tool to measure the skin risk assessment, in particular for the prevention of nasal skin injury. However, it's very important to do the skin risk assessment, which is important to detect the risk from skin injury. And the assessment should be done every shift. And the tool needs to be evaluated for validity and reliability. Not well validated tools are available specific for neonates. Most of the data are reflected from the adult and pediatric population. But there are certain reliable data that can be used during the neonatal risk assessment, such as the Braden Q, Braden QD, the neonatal skin risk assessment tool, or the Glamorgan scale. It's also of importance if the availability of an ostomy or wound care nurse, which can be consulted to evaluate for staging of the wound or hospital-acquired pressure injuries. Prevention is the golden standard to prevent any skin injury. The National Pressure Ulcer Advisory Panel in 2017 released a best practice for the prevention of medical device-related pressure injury. It is of importance to do the thorough skin assessment every shift, and at least to be documented every 12 hours. And the assessment should be thorough, head-to-toe assessment on all skin surfaces. It's very important for the nurses also to lift the medical device or the equipment which is on the body on the infant, and to check the skin surfaces thoroughly. No infant should be lying on a medical device. This is the responsibility of the bedside nurse. And erythema, it's the first skin integrity impairment, stating a sign that there would be a problem. So meaning to say redness of the skin, erythema, it's the first sign to be noticed. As you can see here in the first picture, this is after the saturation probe. When it's removed, this is a erythema post-saturation probe removal. So it's very important to alternate and to rotate the position of the devices, such as the saturation probe or the temperature probe or even the blood pressure probe. Avoid baby lying on any medical device. As you can see, a baby who's lying on a tube, this can cause pressure to the skin, soft skin tissue. Lifting also, as I've said, checking the skin surfaces. So lifting even the ECG loop leads, how much it is light enough, but you can see it started leaving marks on the skin. And the other picture, it is due to the ID band. Even lifting the ID band can cause also a pressure injury. And this is an IV therapy, the last picture. It's an erythema caused from an IV therapy where the baby was lying on the tubing. Positioning is very important. If the condition is permitting minimum of 4-hour positioning, with every position there should be also thorough skin assessment. So that just to check if there would be any, by chances, if there was any medical device left at the back of the patient, of the baby, or for example, sometimes there are leftovers of supplies being used. For example, after medication administration, oftentimes we can see a syringe cup being left at the back of the baby. So this also can cause and create skin injury. If the turning or the positioning is not being possible, so it's very important to have a pressure-reducing supplies to be applied by lifting the head, the shoulders, or even the hips. And to relieve the pressure points, it's very important for the baby or the neonate to be lying on a soft mattress. The incubator mattress are designed to relieve the pressure points of the infant. So usually what the nurses do is part of their bedside care, they accumulate bed linen to provide a nest for the patient. But this is adding extra linen. You are actually defeating the purpose of the baby being resting and relieve the pressure points on the soft mattress. So this is not a good practice. There was a quality improvement being reported which had led to improvement in the skin integrity. And this was after the use or they have applied interdisciplinary skin rounds to identify early identification and reporting of skin injuries. And this had led to improvement in the prevalence or in the incidence of skin injuries being reported in the unit. Another type, after the pressure injuries, the most occurring other injury, it is the application of medical devices, adhesives. And this is referred as MARSI, which is medical adhesives related skin injury. Remember, the premature infants, they have a weak cohesion, connection between their epidermis and dermis skin layers. So with the application of medical adhesives and then the removal of the adhesives, it can actually detach the epidermal first layer of the skin. Usually 10 to 15% of the neonatal ICUs, they will leave the NICU or graduate out of the NICU with the scars. And some of these scars, like 5%, are usually functional or cosmetically serious. The common types of the MARSIs, it's called mechanical injuries, and this is referred to epidermal stripping, which included skin tears and blisters. There is another type of MARSI, which is the contact dermatitis, and this is due to the chemical allergies or chemical dermatitis from certain adhesive types, such as electrodes or certain types of dressing. So again, prevention is the golden standard. It's very important to choose the adhesives which can cause less skin trauma, and the adhesives especially that used to be used or to be qualified or to be chosen to be used, especially on the non-critical lines for the medical devices, for the equipment that needs rotation every now and then, for example, for the temperature probe or for the saturation probe. Advisable to use the tapes such as silicone tape or hydrogen adhesives. In addition, it's advisable to use hydrogel ECG. The hydrocolloid tape, it's advisable, it can be used as a platform for more adhesives such as the ostomy pouches, and also can be used under the certain medical adhesives. It has the ability to mold on the skin and to absorb moisture. The removal of the adhesive skin, there should be a technique to follow. It should be removed in a slowly and very careful way. And remember, those premature babies, they have the tendency to absorb certain toxins from the topical products. So you should not use the adhesive removal on the skin of the premature infants. Rather, better to use moistured gauze. Staff education is very vital for the skin injury prevention. With the staff education, you will ensure at least consistency or standardized assessment and ensure accurate documentation and early reporting of skin injuries to prevent from further complex injuries. It's very important for the neonatal nurses to know about the knowledge and the practical aspects specific to the skin anatomy, neonatal skin anatomy and physiology, and the difference between the premature skin and the term skin versus the adult skin. What to include also in the education, the latest evidence-based practices which are applicable for neonatal skin care interventions and strategies. It's also very important also for the nurses during the education to identify the different types of skin injuries, as well as to identify the different types and assessment of pressure injuries and staging. What we know is that evidence-based skincare practices is optimal for the newborn, infant, and long-term outcomes. However, still some of the neonatal skin interventions are still lacking high level of evidence despite the advancement in the neonatal skin care research. What is expected to be done in every neonatal ICU unit? The neonatal skin injury prevention, it should be a multidisciplinary approach and not only neonatal nursing. It's the whole team, physician and nurses. It's a multidisciplinary. The hospital should have a standardized practice to guide the practice of the nurses at the bedside, and to avoid diversity in care at the bedside, there should be standardized policies and procedures, guidelines to be followed, and this should include the latest evidence-based standards to include in the routine nursing care regarding the best standards for neonatal skin care practices. The neonatal skin care practices, it should be individualized patient care and needs. Reporting of incidents through SRS of OVRs, it's very important, and also to track the incidences, and also to set it as a performance improvement project in order to improve the practice and to measure the outcomes. So the skin integrity, or the neonatal skin care, it's a holistic neonatal intensive care unit approach. There should be buy-in from all the staff nurses in the unit. I can share with you a success story from my unit where I work. We've set it as a unit goal in 2018, a unit clinical indicator goal, which is to maintain the neonatal skin integrity in order to sustain below the internal trigger to get zero, to reach to the outcome of a zero pressure injury stage 2 and above. The work has been divided into 4 quarters, with all the staff being involved into the review, which we have reviewed what were the incidents during 2017, and then we did evidence-based, the staff were involved to do evidence-based interventions with the latest updates in the neonatal skin care and proper neonatal positioning for prevention of hospital-acquired pressure injuries. We did skin rounds, and we have also submitted data to the National Database of Nursing Quality Indicators. This is to benchmark our unit results to check how we are performing internationally. And then when we implemented the ABP, we checked the results in order to achieve the zero happy, and this is what was accomplished as a result. We achieved zero harm. It was a zero pressure injury, zero skin integrity for 2018, and the staff celebrated the success outcomes of the project. Again, I'm repeating again, so the goal of maintaining the skin integrity with the application of neonatal skin care, the major goal it is for prevention of skin injury. So all efforts should focus to achieve positive outcomes for the hospitalized neonates and ensure their hospital stay is free from harm until their graduation or out of the neonatal ICU. Thank you so much.
Thank you very much. Our third speaker today is Pinof Kala. She is Neonatal Registered Nurse, Ministry of Health, NIDCAP Professional Certified 2015, member in NIDCAP. She is guiding 31 NICU MCH under Neonatal Improvement Program, Ministry of Health. She is going to talk about neonatal developmental care nursing perspective. Welcome.
Thank you very much, Doctor, for the introduction. Good morning to everyone. Salam alaikum. And before anything, I would like to thank the organization for inviting me to talk today. And I don't have nothing to close with any organization and institution with my presentation. I'm going to present about developmental care, which perspective with the nursing side, with NIDCAP approach. However, I want to thank you for all the speakers since morning because you make my life easy for my presentation. You did a very good presentation with all the cares and developmental care. Thank you very much. With the reference of my presentation, you can go with this reference. And our objective, we need to empower our NICU professionals, not only for the nurses, but for the multidiscipline. We need to support and appreciate the family, and we need to support the staff to comply about the kangaroo care. So developmental care This is not a new management. This is not a new technologies. We don't need any technologies with developmental care. However, what we need here is our care, especially for the caregiver, not only for the nurses, but for the multidiscipline. The perinatal, among this one, why we need developmental care anyway? Developmental care will reduce the stress of our premature baby in NICU. It also help and prevent the complication of prematurity. Yes, prematurity is still high around the world. However, in developmental care, we will help the baby to prevent the complication of prematurity in our NICU. From the census of NIDCAP Federation International, over 120 million born per year, 20 million for them are delivered early, and 2.6 million died in the first year because of this complication. In developmental care, we have to focus on the 4 approach. What are these? For the environment, it's very important, especially if I'm visiting one hospital. They're asking if I am the infection control. I said, no, I'm a NICU developmentalist. And why should I have to see for the cleanliness of the hospital, especially in NICU? Because it's very important in developmental care. How we approach, how we are going to entertain during the arrival of our parents, from the security, from the safety of our patient, from the entrance of the hospital, for the parking lot, and so on, a lot of things in the environment. For the infant care, how are we going to take care of our babies, especially? Do we have a clear guidelines for the protocol of the skills and competency of our staff? How we take care of the baby with all these guidelines. For the family, do we involve the family as the #1 multidiscipline in our care? Do we comply with the kangaroo care? Do we comply with the breastfeeding in our NICU as the recommendation of the WHO and CDC? From the staff and system, how we support developmental care from the logistic, from the policy, from the administrative, and how we support our staff. Let me ask you, we are all doing our best in taking care of our patient, but when you go home, who took care of you? Who took care of you when you are tired during your duty hours? Your bed and Panadol, right? So that is the one. But in developmental care, we took care of the staff as well. So what we need to empower the multidiscipline. We need to empower especially the skills and knowledge of our professionals, especially our caregiver, who are 24/7 at the bedsides of our babies. Now, we're just only few developmentalists in the kingdom. However, our aim is to have our future NICU developmentalists in every region of Saudi Arabia to guide this process and to continue the care of our newborns in Saudi Arabia. Because we are non-Saudis, and later on, sooner or later on, we will leave the country, and who will going to support the newborns as the voice of the Saudi Arabia? We have now our ongoing professionals, and sooner, after 2 years, you will have your own developmentalists in every region. And now we have in process and identifying in every region to support them and give them the continuous training in MC in the mom. So you will see, maybe one of you here is attending all this training for the developmental care in NICU. Also, under NICU improvement program, we have also the delivering of updates in every region. So we are supported by the NICU improvement program. In developmental care, It was, I told you, you make my life easy from the first speaker because you give already the developmental care will start from the delivery room. It was stated clearly for us from the recent speaker. How are we going to stabilize the baby from the 1 hour to golden hour? How are we going to stabilize the baby? The NRP guidelines, the stable guidelines, as well with the golden hour guidelines, it's very important in developmental care, where the baby can already receive complication of prematurity from the time of delivery. However, even from the 72 hours of care, how are we going to take care of our baby, especially stabilize the physiological status of the baby? The thermoregulation is very important because once the baby will be hypothermic, what will happen within 24 to 72 hours, the baby will die. And during the admission to NICU, how long the baby will going to travel from delivery room to NICU? So that is very important also in developmental care and protecting the brain of the baby, because from there onwards, from delivery room, the baby will going to develop brain hemorrhage or IBH. Then during the care, what are the competencies, the skills of our staff? Are we going to allow the staff without all these skills? Because this is very important for the morbidity and mortality of our patient in NICU. And our goal is to empower our staff, and our goal is we will going to send off our baby going home without the complication of prematurity, like hearing loss, blindness, deaf and mute, physical and mental retardation. So this is all about the complication of prematurity. We have also 3 systems affected. We have the heart, the brain, and the respiratory. So this is always matter in developmental care. And the transport system is very important. For the 3 systems affected, this is all the system that affected in developmental care. For the cares, I'm going to reiterate one by one, and I wish I can give you until at the end of my presentation. For the positioning and nesting, this is very important. How are we going to improve this process? This is very important for the good brain outcome of our newborn baby, especially for the premature babies. So if we're going to put the baby on good position, in midline position, the baby will not feel discomfort, the baby will not feel pain. So there will be no extra demand for oxygenation, and all the physiological status will become stable, and there will be better outcome. If there is more good, comfortable position, the baby will sleep more, and there will be better outcome with the brain development. We have a lot of opportunities that is happening right now. We need to improve this process. However, logistic issue is the problem. We need the administration, we need the system, we need our government to support us with all our needs, because it's still, even in the province, we are lacking with a lot of logistic, and this will affect the morbidity and mortality of our patient in NICU. So this is high that we still need to improve of opportunities from 2017 when it started in the Ministry of Health and 2018. So we're talking about nesting. So nesting and positioning now, we have now a great improvement in our NICU. From 2017, you can see now the difference of the care of our baby in our nurseries, which is very important for us to empower our professionals, to give them the competency, the skills in the education and training. So it will also benefit especially the good outcome of our babies. So this is how we call the nesting, where we are mimicking the baby, because they come early from the early life of prematurity outside the world, so we need to mimic their environment. Still, this is all the opportunity to improve. Still, we can find this in some other nurseries, but we are not stopping. We did not stop in supporting these nurseries. However, we continue to support them to improve their practice. So after the implementation of developmental care, this is now what we have right now. So I'm very proud to present to you that these are all the cares now in 2019. But another thing in developmental care about nappy chains, what is the relation of developmental care and brain development with the diaper? One nurse asked me, well, how this diaper will affect the baby's brain development, how it will affect with IBH. And then I told to the nurse that it's very important, you have to be skilled enough in how to change the diaper of the baby. So we are no longer lifting the leg of the baby. We are no longer doing using the inappropriate size according to the age of the baby, because the complication of using not the proper size for the baby, the complication will develop a pelvic fracture and leg fracture. And for lifting the leg, it's no longer practice, and we have taught our nurses on what is the proper way of changing the diaper, because this is especially for the premature baby, and we're not recommending from delivery room to put diaper from delivery room going to NICU, because from delivery room to NICU, from NICU when the baby arrives, again they're going to remove that diaper and they will put another diaper, and again they will manipulate the baby by lifting the leg. So if the nurse is not skilled enough to change the diaper, from there onwards in delivery room, the baby will develop IBH1. About the feeding, it's very important also to enhance and nurture the professionals, and most especially to involve the family. We need the mother to involve in feeding. Not only the mother, the father, doing kangaroo care, breastfeeding, and most especially for the nurse to sit down comfortably. And we need to support the baby during the oral feeding, because you will not have a successful oral feeding if the baby is not comfortable in a comfortable position. We also recommend not to tap the back of the baby and rub the baby. So we taught the nurses also on how to support the baby during the feeding and burping. And we recommend also from the ventilated babies that the nurse should sit down beside the baby during the feeding, because the nurse can control the feeding when the baby is deteriorating, and she can observe clearly the baby and for the safety of the care. And most especially, we don't want you to get tired throughout the 8-hour and 12-hour shift. If you handle 2 or 3 babies feeding tube, at the end of the duty, you will going to tell to your head nurse that I'm sick leave because I have back pain and leg pain. So we need also to support the baby during the procedures like echo and ultrasound. Do not leave the baby, contain the baby, because the baby is in stress. How are you going to handle? Because the technicians sometimes do not care what happened to the baby, and sometimes the baby deteriorates because the baby is in pain. And if the parents is there, it's their right to help their baby, whatever our guidelines in our NICU. But don't forget the guidelines from the infection control, from the WHO, the 5 moments, hand washing to every multidiscipline, and most especially our parents as well. Here we're talking about the sensory motor, about the noise level in NICU. We have a lot of studies already ongoing with 2018 published that in starboards in France, that they are now using the decibel meter of 30 decibel meter, which you cannot hear anything inside NICU, which the acceptable is 45 to 65, that is from the NICU Federation and to the American Pediatric. This is the acceptable, but now they are doing the study of 30 decibel meter, which they shown to us virtually how the baby reacting, and the brain is pulsating with that very sensitive brain is developing IBH through the noise level in NICU. And the complication of noise level in NICU, if the baby is exposed, there will be a complication of hearing loss, speech and language difficulties at the age of 2 to 3 years old, and a long-term complication is being deaf and mute in the future. So this is the complication in NICU. And however, the baby is not sleeping also in the NICU because of the noise level in NICU is not controlled. So what do we need to, the recommendation, we need to modulate our voice, we need to use incubator cover, we need to have the indicator that we are going already beyond the acceptable parameters. So the modification of environment is very important as well, and also in the same university in Sweden, they are having now and published already that the most acceptable parameters of lights that the baby can receive, especially for the premature baby, is 200 to 400 lux. But now they have shown the evidence already from 35 lux. Imagine what kind of that environment we have already with the 35 lux. It's almost dim already, and with that, with the result of the 35 lux, 100 lux, and 300 lux, it came that every 30 to 60 seconds the baby is awake. So meaning our baby is not sleeping in our NICU until they're staying in our nursery. So what is happening? The brain development is in trouble. So with 30 lux, which is acceptable from the NIDCAP Federation and from the American Pediatric guidelines, 200 to 400 lux. This is acceptable for the babies with the incubator cover, and the dim environment. This is 200 to 400 lux. But in Paris right now and France, they are already practicing the 30 lux to 100 lux only, because as a result for this study, every 30 seconds, not minutes, 30 seconds and 60 seconds, the baby is awake. So there's no brain development at all. And we need also to follow the guidelines of the cleanliness and orderliness of our NICU. And then another thing is the sensory motor. So this is the problem in our logistic in our system. We don't have enough what is the appropriate eye cover. This will cause infection to the baby, and the main complication of this is blindness. It will not support our baby at all. As I told you, what is the acceptable light that the baby can receive is only 200 to 400 lux, but with the single phototherapy, that is 2,000 lux. Double phototherapy is 6,000. How about the extensive going to 8,000 to 10,000 lux, as bright as you are already under the sun? So it will going to complicate also the eyes of our baby in the future. So what is the recommendation? We need appropriate support during the phototherapy. And we need also to support the kangaroo care. Kangaroo care is very essential. What is the kangaroo care? This is very essential for every preterm, especially for all the newborns, because this is what is the better outcome for the brain development. These are all the benefits of kangaroo care. Physiological status, especially for weaning and oxygenation. If you want to wean your oxygenation, especially if the baby is in ventilation and conventional, in other nurseries around the world, in the first world country, they even do kangaroo care with a high frequency, because this will help to extubate the baby from winning the oxygenation. So kangaroo care is best recommended by the WHO, and this was, we have an evidence from the Bogota, Colombia, with Dr. Dr. Natalie and her team, and even to the researcher in Canada. We have a research in Canada. For 20 years, they have all the evidences. And it was recognized by the WHO since 2003, the KMC, or the Kangaroo Care Guidelines. And we have a lot of researchers still ongoing around the world. And this coming May 15 is our Kangaroo Care Awareness. It's very important that we need to support and educate our nurseries, our families, the multidiscipline. We need to educate our society the importance of kangaroo care. So I would like to invite every one of you that you have to celebrate this like we are celebrating for the World Prematurity Awareness. And we are now joining the international again for the second year for the Kangaroo Care Awareness. So now this is now the trend in Saudi Arabia. Initially, one of our colleagues from USA and from UK, they said kangaroo care can never be in Saudi Arabia. And I object for that. No, we can do kangaroo care in Saudi Arabia. We can do breastfeeding in kangaroo care Arabia, aside for the sensitivity of our culture. And this is now our trend from 2018, 2017, 2018, and this is now the 2019, that even the father is doing kangaroo care. And I just want to reiterate that our first father who did kangaroo care in Saudi Arabia is a military man. So this is the one that we need to support now in our NICU. So this is the effect of kangaroo care. This is one of our patients who's already on high frequency for 25 days, 1 month in conventional, and after that the parents doing kangaroo care every day, twice a day, and afterward this is now the baby. Batting also is, we need also to support this process. We need the guidelines, and we have also the benefits of the delayed batting. We are not recommending to bat the baby upon delivery because we have all the benefits and we have all the evidences. So we have also to check with our guidelines how we support our babies in the pain management, and especially for the intubation. We need also, I know that we have a lot of consultants right now and neonatologists that working with the guidelines of the pre-medication of intubation, and we need, this is very important in every NICU. Still we need to improve all this process. And we're not recommending to puncture the baby, especially to get from the brachial and radial hand, and we're not recommending this in an ICU. So we need to be strict in our guidelines and policies. We need also to improve this process, especially for skincare, for umbilical care, especially for the ICD, how we will secure. This all needs for the skills for the caregiver. We need also the logistic from the appropriate transport from delivery room. There are nurseries that are not using the appropriate transport in delivery room to NICU, and this is, we're looking about the safety and the safety of our baby during the transport. And we need also to look forward for the non-pharmacologic and pharmacologic guidelines in our NICU. So what are the non-pharmacologic and pharmacologic? We need a clear guidelines for every NICU, and I know you are all here to help me with these guidelines, and most especially the non-pharmacologic, we need to use the pacifier. Even though you are in the baby-friendly hospital, pacifier is allowed in NICU. So breast milk is the most important if we don't have the sucrose. Alternative for the pain management for non-pharmacologic is the breast milk. So we have to know the behavioral cues of our babies. We need to know how to read them. So this is very important for us to assess. According from Dr. Brazelton and his team from Boston Hospital, they identified this behavioral cues from 1970s. This will help us to assess our babies' sensitivity and their strength. And we're going to help them and how we're going to support these babies. So in order to know our improvement in NICU, so these are all the data that we need to assess in every per delivery per year. So from the recommendation from the International Pediatric Association, it should be our IBH grade 3 and 4 bilateral should be below 10% above the international benchmark, and from the ROP and SARDI guidelines, also it should be 10% below the international benchmark, and you will see that you are improving your care in your NICU. So what our protocol guidelines also is still we are seeing admission area in our NICU. So you have to go with the protocols. We have all the guidelines and protocols already in the leveling and criteria in our admission and discharge in NICU, and this is not acceptable at all. For the environment, we need to be clear with the environment. We need to go with the cleanliness of our environment. How are we going to support our environment to become clean and safe for our baby? For breastfeeding, it's very important. The logistic is very important. And for the support of our staff, this is how we need to go with the guidelines and protocol, especially for the competency of our staff. There's a lot of nurseries that they are not looking forward for the competency of our staff. So the administration and the national guidelines for Saudi Arabia, especially in an ICU, we need a skilled staff. So we need to support also our staff with their care area, with area not only for the nurses but for the multidiscipline, in order for us to give us a quality care. And we have also published about developmental care abstract from 2018, so you can check this one in the website. And our end conclusion is to empower and bring our baby and support our baby in developmental care in NICU. So thank you very much, and apologize for the extension of my presentation.
Thank you very much. I think we are running shortage of time. Yes. Okay. Okay, we can allow 3 questionnaires. So, question open. Yep, you can have a seat. Okay, sorry.
Yeah, this is just for Mrs. Kala. I thought you mentioned that there is a correlation between diapers and IVH. Did I hear it right? How come?
Yes, doctor, there is a relation with the diaper, because especially the procedure on how to put the diaper. And the example is for the premature baby, we're not allowed to lift the leg of the baby, especially from the time of delivery. Lifting the leg of the baby, it will cause the gush of blood going to the brain of this very sensitive premature. So in one day or in one shift, how many times the nurse were going to change the diaper in lifting the leg of this baby's doctor? So that is the number one complication.
Any studies on this?
Yes, doctor, there is an evidences from all the developmentalists, from developmental care, from the NIDCA Federation International. So we have all the evidences with all this practice. That's why it's already a 40 years decade for the developmental care, studying all of this on how we're going to take care of the brain of the baby, especially for the premature babies.
Yes, please.
Assalamu alaikum. Question for Mrs. Khulud. For the regarding the golden hour of practice, we noticed that there is a gap between the NRB courses and in the real practice. after attending the NRB 12 hours to 72 hours, then again, same mistake, same sometimes panic, non-organization. As we need more courses or monthly courses in the real practice, maybe we called it PNR, practical neonatal reality, or something else.
Yeah, this is why I mentioned that there are some facilities who are conducting frequent simulations in their organization to help practice for making sure to break this fear and to make sure that there's constantly, the staff knows what to do. The entire team is usually involved. The nurses with the physicians and even the consultants are conducting these frequent simulations, and it's exactly as the NRP practice, where they write a scenario, they do a complete drill with a simulation, and then they're going to do a complete debriefing after that.
I think we'll end this session because we are short of time. Sorry for this. Thank you very much for all.
So we'll start our last session. So I would like to invite Dr. Adnan Chitawi. Dr. Adnan is a consultant neonatologist, and he's the director of Neonatal Perinatal Fellowship Program at Tabuk Armed Force Hospital. And he will share this very interesting topic about neonatal debate. Okay, Dr. Adnan.
تصير كذا تصير الفونت واضح لك؟
واضح، ما عندي مشكلة. ما عندي مشكلة.
خلاص. بس بالنسبة لهذا ويقرأ من اللابتوب حقه. خليه يجي هو أول واحد. طيب.
أنا أفتح ولازم هو يفتح. المشكلة إن الحين كذا لازم مع بعض.
لا خليه واحدة هو يقرأ.
خليه أسمع واحدة كذا واحدة.
Good morning. We'll start the last session for this morning, about neonatal debates. We'll start this session by a lecture about enteral feeding in preterm babies, which will be presented by Dr. Saad Saadi and Dr. Abdul Hakim Qattan. Dr. Abdul Hakim Qattan is a consultant neonatologist, Department of Pediatrics, King Faisal Specialist Hospital and Research Center, co-chairman of organizing committee of this conference. He's a current board member, Saudi Neonatology Society. And Dr. Saad Saadi, because this lecture will be sharing lecture. Dr. Saad Saadi is Associated Professor of Pediatric Faculty of Medicine, King Abdulaziz University, Jeddah. He's a former president, Saudi Neonatology Society, Neonatal Society, current board member, Saudi Neonatology Society also, and Dr. Saad Saadi is a chairman, Saudi Neonatology Club meeting in Jeddah.
Just our apology, there is some technical problem here, so just...
Assalamu alaikum. Good noon for everybody, and thank you for the organizing committee. And it's, for me, it's a new idea altogether to have a joint type of presentation. But it was good that I am with my previous boss in the society, Dr. Saad Saadi, and we tried to make it one presentation, but the technology didn't allow us. So we will talk like, I will take 5 minutes, then I will give more time for Dr. Saadi to give you the, the evidence base for the topic. In general, as you know, in your practice, dealing with the feeding of prematures is a major issue, and it's a daily work. Every day will come from the morning round, and you find most of your baby, 50% of them MBO again, though you want them to progress with the feed. So usually it's a major issue, the issue of feeding and how to reach. As you know, the premature have inadequate nutrient stores. They are immature physiological system and rapid growth rate, and they have a lot of medical complications and illnesses that increase their need for calories, that many times we have a lot of limitation to do it internally, or through the through the gastrointestinal system. When the agreement between me and Dr. Saadi was to talk about two aspects only of feeding intolerance and management, and we will concentrate only in gastric residual. And so I will present my part, gastric residual, and the second part will be prokinetics, the use of prokinetics, and to see how frequent we are using it and is there any basis to do it. So gastric residual, it's not unusual to see gastric residual in the first 2 weeks of life of most of the prematures. And it's a benign phenomena. And sometimes it can be greenish because they have loose, pyloric sphincter, and they can have some reflux from the duodenum. And usually consist of the gastric secretions. And many times doesn't indicate intolerance. Usually it indicate immature motility of the bowel, and more than one study, it's not much related to neck and or impending neck, unless there is other signs of neck, so that we will go over it soon. This is some work done earlier showing in the first 2 weeks. You don't see the cross there, but in the left side of the slide, you see in the first 10 days of life, the residual is quite common. And as baby become more mature, then the residual will reduce spontaneously. So checking residual every 2 hours, every 4 hours, every 6 hours, nobody knows exactly how frequent we should do it. And this is the reason, it's a bit debatable, issue, and you'll find in many of your protocols at your work, you'll find check residual. And most likely, most of you are doing it. If you are not doing it, the nurses are doing it. So part of the immaturity of those premature, they have gastric emptying delayed, and they have duodenal reflux. They have, of course, as the most feared part is the possibility of neck and the irregularity of the movement of the intestine. Signs of intolerance: vomiting, gastric residual, as we talk about it, abdominal distension. So typical protocol of feeding in many nurseries talking about measuring the volume of aspirate. If it is less than, if you are feeding more than 5 ml, then you consider, is it less than 30% or less than 50% or more than 50%, and you have action from that. Actually, I have the chance to go over the Saudi Neonatal Society protocol for feeding, and they are doing that. They are asking for residual and doing that. So maybe we should revise also this. And Dr. Saadi was one of the people who, helped in developing these protocols. The type of the residual, is it the usual, milk, curd milk, the semi-digested, or is it dark green and bilious, and the quantity and so on? So there is many studied part of it that's difficult to tell. And then most of the protocol will tell you if the aspirate is refilled, don't count that in the volume, in the feeding column, the volume column, and then if the volume of feeding is decreased, adjust the IV, and so on. So if it is more than 50, many of those protocol will act to it and consider evaluation plus to omit 2 or 3 feeds than to restart again. If it is below 50, some people, also omit feeds and then reevaluate. And, less than 25% usually people, they just go ahead and continue. We said residual by itself is not sign, but if it is combined by other signs of necrotizing or early necrotizing, you should keep it in mind. Of course, clinically unstable babies, grossly bloody or watery stool, and visual bowel bloobs and bilus or bloody aspirate. Type. So that's in general about residual and how we deal with it. That, though I am not maybe so interested to look at it, but it's part of your practice. So before I leave this topic, how many of you in your unit check residual on the baby and act on it? How many routinely check residual in premature and act on it? Can we see hands? How many? Yeah, so a significant number of you, most of you. So, which is, I think this is the practice. We go to the second point, or the second part of the things, the prokinetics. Prokinetics have been, used widely in the intensive care unit for neonate. Many times we were using it 2 decades ago, 3 decades ago, during our fellowship. When we were doing, fellowship in Canada, it was very common to use Cisabride. And some of you, the old enough to remember that era, it was a successful drug. we have a lot of positive feedback from doctors about it. And actually, there is some small studies saying about the efficacy. Then it was withheld, and there was alert about that drug, and it should not be used because of the side effect, cardiac side effect, arrhythmia, the QT interval being prolonged, and there was some deaths related to that. So no more. Cisabride is gone. Now the question is, what is about other drugs? So if you think about other drugs, there is the dopaminergic agent that stimulate the gastroesophageal sphincter, stomach, intestinal motility, and usually it's metoclopramide and domperidone. And both drugs have some side effects, and many people, they are trying to avoid it. The more used one, and this is just example of cartoon of the issue of relaxing the sphincteric muscle of the biliary area to improve the emptying of the stomach. Erythromycin is have been studied in many small studies, and actually there is some Cochrane review about it. It was published in 2008. It's old. There was 7 studies, and there was no much conclusion at that Cochrane review, and they are not recommending it. More recent, in 2011, there was some review about it in current opinion of pediatric, and they were talking about high dose erythromycin may be justifiable in some cases. So again, erythromycin is, though some people, they may use it, and I don't know how many of our colleagues, they are using prokinetics, and they use them in the practice. Do you use prokinetics for premature, difficult to feed? Any hands? Okay, I'm seeing it. So people, they are using it. We are using erythromycin, most of you using it. The main issue about erythromycin is an antibiotics. It may change the gut flora, and you may have entered into some other problems. I will stop here, so I will not take the time all. And My colleague, Dr. Saadi, should go ahead and.
Thank you, Dr. Abdul Hakim.
Thank you, Dr. Abdul Hakim. I maybe agree with you with some, maybe disagree with others, but we agreed on a conclusion at the end. What about gastric residual? Gastric residual measurement in preterm infant. It's a common, almost in every unit. I don't remember any unit I worked in it or my colleague who worked in other unit, they don't use, they don't measure gastric residual by one way or the other. However, it's really tradition, unfortunately, with little scientific evidence exists to justify this practice. Also, gastric residual is often evaluated in preterm infant to guide feeding as indicator of feeding intolerance, as well as considered as early sign of NEC. What to do with gastric residual? Decisions regarding when to discard gastric residual are not existing and not based on scientific basis. The gastric residual included nutrient, gastric acids, and enzymes that may be assist in the promotion of intestinal motility and maturation. So if you discard it, a problem. Also, other clinical management of gastric residual. What to do with it? Again, as Dr. Abdul Hakim Gattan mentioned, some unit they use 50%, some of them they use 20%, 30%. Whether some guidelines add to it, whether the color of it. So standard for management of gastric residual are lacking. Also, a wide variation in the practice regarding the evaluation of feeding tube positions, regarding the frequency of gastric evaluations, how frequent, 2 hourly, 3 hourly, 4 hourly, every other feed, no, different, and not based on tradition, not on any scientific basis. Also, the evaluation of like standard regarding when to discard or return the gastric residual. Some units they don't return it, some units they return it. So again, there is no standard for this. What constitutes significant feeding intolerance? Is it the volume of gastric residual? Is it the color? Or both? So what is feeding intolerance? Also, there is no agreement on the definition of feeding intolerance. Increased volume or of the gastric residual or its color. Is it abdominal distension or vomiting or combination of those? Also, controversy exists regarding the use of gastric residual as indication of feeding intolerance, because there are other factors play a role in the feeding intolerance. What is the volume of gastric residual that tell me that there is feeding intolerance? So, lack of uniform standard led to discontinuation of enteral feeding or delay in the enteral feeding advancement. This lead to unnecessarily prolongation of TBN and period of MBO. Also, increased risk of late onset sepsis, because the more you continue on TBN, the more risk of late onset sepsis. TBN cholestasis also is another risk. And also, if it may lead to extrauterine growth restriction, which is, I think, very important. And optimal growth is one of the goals of management of preterm infant. Gastric emptying correlates and influences in gastric residual. The gastric emptying is directly related to the gastric residual. The better gastric emptying, the less gastric residual. Let us look at the factors which affect gastric emptying. There are intrinsic factors which is related to the immaturity of gastrointestinal tract. For example, in uncoordinated suck and swallowing, lower intestinal transit time, in immature lower esophageal tone and function, low percentage of gastric electrical slow wave. This are intrinsic related to prematurity. Also, there are extrinsic factor. Nutritional management. It has been shown that breast milk, when it's compared with formula milk, improves gastric emptying. Also, hormonal input and drug administration. Some of them enhance gastric emptying, some of them delay it. Other factor delay gastric emptying, which relate to increase gastric residual. For example, factors which may delay gastric emptying, formula milk when it's compared with breast milk, thiophyllene. Also, Midriatic, which you use it frequently before examination of the retina for ROB. Also, some disease state like BDA, necrotizing enterocolitis, sepsis, and hypotension. What about other factors with increased gastric emptying? As I said, breast milk, antenatal corticosteroid, prokinetic, as mentioned by Dr. Gattan, and enteral feeding per se. So, unanswered question. What is the gastric residual volume indicate feeding intolerance? No answer. Does a change of the color always indicate feeding intolerance? How frequent you should measure gastric residual? Does the color of gastric residual is as indicator of NIC? Enteral feeding, unfortunately, frequently discontinued because yellowish or slightly greenish gastric residual, resulting unnecessarily delay in the attainment of full feeding. So, several studies, just I'm going to go through them quickly. Studies by Mochatat and Chalman, two different studies, showed that gastric residual is unreliable indicator to predict the attainment of full gavage feed. Also, green gastric residual were not indicative of feeding intolerance, and their presence should not delay the feeding. Relationship between gastric residual and NIC. While some studies suggested that increased gastric residual volume may be an early indicator of NIC, other studies did not find any relationship, and all these studies are really small number and they have methodological problem also. Maybe the first or the second randomized control trial in this issue, which was published in Pediatric 2018, it's a randomized double-blinded control trial, concluded avoiding routine assessment of gastric residual volume before feeding advancement did not shorten the time to reach full feeds. That's contrary to our belief. In preterm infant with a birth weight of 1,500 to 2,000. No difference in the incidence of NIC. So this, I think, very important factor to know. At least now there are two randomized control trial taking underway to evaluate whether there is a need for routine measurement of gastric residual or not. One of them in our center in King Abdulaziz University, Jeddah, almost maybe a few months, and we're going to finish the study. So conclusion, The routine practice of checking gastric residual prior to enteral bolus feeding in very low birth weight infant is not evidence-based. It may be harmful. Whether this practice should be discontinued or should only be used to evaluate infants showing either clinical signs of feeding intolerance is an important question need to be answered by a randomized control trial. So at this point, gastric residual volume or color alone, without looking at other factors like abdominal distension and status of the patient, should not be the only cause for holding feeding intolerance. Prokinetics, I think Dr. Abdul Hakim Gattan went through it. I think the most important one studies is erythromycin, and as you know, the strong motilin receptor agonist stimulate cholinergic nerves of the gastrointestinal tract and also induce phase 3 activity of the interdigestive migratory motor complex propagating from the stomach to the ileum, and this is very important part of the digestion and enhance gastric emptying. It's dose dependent, it's effect dose dependent. So the literature has been 3 different oral dose, high dose, intermediate dose, and low dose. And also its effect is age, gestational age dependence. It has been decreased, it has been shown that decreased effectiveness in the more preterm infant less than 32 weeks when it's compared with those more than 32 weeks. One randomized controlled trial of erythromycin in very low birth weight infant with feeding intolerance at age 14 days of life. The erythromycin group had shortest time to full feeding, fewer days of TPN, fewer of TBN associated cholestasis, fewer episodes of late onset sepsis, no difference in the side effect. Another randomized controlled trial of intermediate dose of erythromycin in low birth weight infant with a birth weight, gestational age less than 32. When the gastric residual of 50% or more of feeding in 2 occasions in 24 hours, this is one of the inclusion criteria. They found that shorter time to full feed, fewer episodes of withholding feed, no difference in the side effect. However, as Dr. Abdul Hakim mentioned, there is a Cochrane studies in 2008 concluded that has a small dose has no rule. However, there is limitation for this review. Study difference in patient population, dosage, outcome measure. So, possible adverse effect, several epidemiological retrospective studies had shown increased risk of biliary stenosis and cardiac arrhythmia. This is more with IV preparation, but no one of the randomized control trial report any one of these side effects. Domperidone, in brief, has been used a lot as in babies with frequent apnea and bradycardia, in babies with increased gastric residual, in babies, in children with vomiting, and children with gastroesophageal reflux. Most of the study done in children, infant from 1 month to 11 years. All of the studies, with a few, didn't show any change in the reflux disease. Few studies in preterm infant. So, in addition, there is a warning from FDA with cardiac arrhythmia with its use in IV preparation. So, until now, I don't recommend its use, as well as metoclopramide and also there is a lot of reports of extra pyramidal side effect, so it's not recommended. So, conclusion, the empirical prescription of prokinetic in preterm infant to improve enteral feeding is widespread. The overall available evidence regarding the efficacy and safety of prokinetic in preterm infant are quite limited. Probably erythromycin is the most one studied well. However, there is a lot of limitation for these studies. If I'm going to use one of these three, I will use erythromycin. But I should be cautious in certain situations. Thank you very much, and we apologize for being take more long time than what we have.
Thank you, Dr. Saad. Thank you, Dr. Abdul Hakim.
Can I have comment for Dr. Saad? As it is to...
Dr. Abdul Hakim, but because of running of time, can we do all, then we do discussion?
Okay, fine, fine, no problem. No problem. Okay.
We'll move to the next topic. Will be about neonatal cooling bedside controversy. It's again a co-joint presentation by Dr. Zakaria Salam and Professor Turki Al-Kharfi. Professor Dr. Turki Al-Kharfi is a professor of pediatric faculty of medicine, College of Medicine, King Saud University, and senior consultant neonatologist at King Khalid University Hospital, King Saud University Medical City, former president, Saudi Neonatology Society, and co-founder, Saudi Neonatology Society. And Dr. Zakaria Salam is a chief medical officer, consultant neonatologist at Al-Zahra Hospital, Sharjah, United Arab Emirates, and co-member 19th Saudi Neonatology Society Organizing Committee. You're welcome. Dr. Kharfi,
thank you very much. So what we will do, it will be a little bit different than the previous presentation. So I have the pleasure to co-present or participate to a minor degree to the speaker who is my professor, and I have learned a lot from him. Maybe, I don't know, 5 years, 6 years we worked together. So I'm very much influenced by his practice and meticulous practice, I would have to say. So what we will do, I will ask questions, and Professor Turki will answer them. And we will start with Doctor.
Yeah, I would like to thank Dr. Jubar Allah and the organizing committee for the invitation. Assalamu alaikum wa rahmatullahi wa barakatuh. And I hope at the end of the lecture we will have some agreement on some disagreed or issue of the cooling practices. So, go ahead.
We'll start with the first thing. As you know, that we have a lot of, especially after I moved to the private, we have a lot of medical legal cases in the form of litigation, and it's well known asphyxia is one of the most cases that go to the court, and so now there is a hope for us in the form of hypothermia, but again, sometimes they say start, not to start, why did you start late, and so on. So I will ask Dr. Turki is that what would be the best protocol that will protect us from the medical legal litigation, as well as protect the patient, of course. So what do you think in your mind?
Okay. The inclusion criteria and the exclusion criteria of babies with HIE to go under hypothermia is well established, and it's well published. I'll just go through two quick inclusion criteria which being used in the randomized controlled trials. The first one is the inclusion criteria which was published both in the ICHD trial and on the TOBI trial, and they made them similar because they wanted to compare the result of their study in a meta-analysis in future. So they made their inclusion and exclusion criteria the same. The baby need to fit two different criteria: the physiological criteria, which mainly talks about the cord pH, or a blood gas, arterial blood gas done for the baby in the first 1 hour of life, to have a pH which is less than 7 with a high base deficit. The neurological criteria is the presence of seizure activity. For example, if the baby develops seizure activity secondary to HIE, it's an automatic inclusion criteria. All right, baby can develop seizure activity due to other things. But if you think this is due to HIE, then this is by itself an inclusion criteria. Physical exam compatible with significant or moderate to severe HIE. I used Thompson score as an indicator of the significance of the HIE. Thompson score more than 7 is considered to be an indicator of moderate to severe HIE. Or any one of these is needed. Abnormal amplitude integrated EEG if it's available. The American College of Obstetrics and Gynecology and the American Academy of Pediatrics jointly published protocols for criteria of inclusion in therapeutic hypothermia, and their inclusion criteria similar to the trials, a significant or profound acidosis, metabolic or mixed, presence of or persistent of low Apgar score, more than 5 minutes, finding of neurological sequelae due to the HIE, seizure activity, coma, or hypotonia, maybe multiple organ dysfunction or involvement is part of it, and an age of less than 6 hours after birth. Exclusion criteria in their document included a chromosomal or severe anomaly, congenital anomaly, premature, babies less than 35 weeks, we'll talk about that in the future, and non-viable fetus or infant. Go ahead, Doctor.
You know, sometimes we come to the round after the age of 6 hours and we notice the patient's qualified for hypothermia. So is there any rule for that after the age of 6 hours?
Okay. This is a study which was published by Laptock and et al. Answering this question specifically, and babies who qualified or was transferred to cooling center after 6 hours of age, which is, we know, the therapeutic window or the opportunity window. This study or the trial is randomized control trial, cooling babies after 6 hours and within 24 hours of birth, and they looked at their death or disability at follow-up of 18 to 24 months of age, and they called the trial the late hypothermia trial or the LH trial. They had in that trial, about 80 babies in each limb of the study, and there were 93% obtained, a follow-up was obtained. They found that there is about 24% of babies who were cooled developed the primary outcome, which is death or significant neurodevelopmental delay, versus about 28% in the babies who were not cooled. So there was slight difference between the two groups, and they did something called the Bayesian analysis because the number of groups are small, and they wanted to see what will happen if they continue doing that in a bigger scale of study. And they found that the probability, 76% probability of producing the primary outcome, and at least 2% reduction of that outcome in 76% probability. And if they go on to 2% reduction or more, then the probability dropped to 64%. They concluded that the positive effect of hypothermia initiated after 6 hours of life is uncertain. And they stopped at that stage of conclusion. There is another study which comes from China. Tong Chan and his group looked at the same question, but they cooled babies within 10 hours after delivery. All right? And they found there is a positive response of cooling. They have about 40 babies in each limb of the study, hypothermia and control, and that the disability was decreased in the hypothermia to 16% compared to 43% of the controlled group. But mind you that most of the babies who were cooled in this trial were cooled in the first 6 hours. So they extended to 10 hours, but majority of their patient was cooled in the first 6 hours. When they looked at the subgroup analysis of babies who were cooled in the 6 hours versus babies who were cooled after 6 hours to 10 hours, they still found a difference according to them. So if I see a baby who come to my care or transfer to my care or to any therapeutic hypothermia center after 6 hours, I think from the available evidence, I think cooling should be offered to this baby. Of course, if it is more than 24 hours, then maybe the benefit of cooling definitely will not be there. Still, I think we need further study to further delineate this question, but this is the available evidence at this time.
Okay, so what about smaller babies or babies less than 35 weeks? Can we do that?
All right. There is a small ectogal studies which looked at this question, cooling premature babies or near-term babies less than 35 weeks. And all of them, they didn't have a good follow-up, a long-term follow-up. All right. The only study which was big enough is the study from Rao, which actually found more deaths in the premature group who were cooled. Mind you that the ICE trial and the ICAR study included babies who are 35 weeks, so to 36 weeks. The standard is 37 weeks and above, but in the ICE trial, which is a multi-center randomized control trial, a big number of babies, looked at babies who were cooled at 35 to 36 weeks, and they found their outcome was similar to babies who were cooled after 37 weeks. So would you cool babies who are near term? I think we need to wait till this study comes out. This is a randomized control study which is underway now. It is by Shankaran and her group, and it is start enrolling in 2015 babies who are near-term babies between 33 to 35 weeks. They want to enroll 168 babies, and their enrollment is supposed to finish by 2020, and hopefully we'll have some information from this study after that time. This is the only study which is done which will be done looking at this question specifically: premature baby or near-term babies and therapeutic hypothermia. I would say now, cooling babies less than 35 weeks is not proven. It may have some side effects, and the available evidence doesn't justify cooling premature babies less than 35 weeks.
Okay, so if that's the case, so how about doing it in mild HIE or Sarnat stage 1? Is it possible now? Because
That's a more difficult question to answer, because there is no study which up to now targeted this question, or there is any planned study in the future to be done. We know from some small trials that premature babies or near-term babies, when they are subjected, full-term babies, when they are subjected to a mild HIE, all right, full-term baby, when they are subjected to mild HIE, they have problems in their future. 16% in this study by Chalak developed disability from mild HIE. As well, another trial by Conway looked at full-term baby with mild HIE and meta-analysis, and they looked at 20 study, systemic review, and they found that in this 20 study, the baby who developed mild HIE, there were abnormal outcome in 25% of these babies. So mild HIE does not mean 100% normal outcome in the future. This is, we know from the information available. 16 to 25% of them, of these babies, would develop significant or some degree of neurodevelopmental disability in the future. Now, this is a meta-analysis which was done by Conralo, and it was published in the archives recently in 2018, who looked at babies who had mild HIE in the multiple studies, randomized control, multi-center studies like TOBI, like NICHD, like ICE study, both selective head cooling or whole body hypothermia. And they found that these babies, when they were cooled, they were indefinitely cooled. They were not supposed to be cooled by the study protocol, but they indefinitely cooled. Somebody decided to cool them, and they thought that they have significant or moderate HIE, but they didn't. When they cooled them, they looked at the outcome at 18 to 24 months, and they found that the babies who were cooled had the primary outcome, which is death or significant neurodevelopmental delay, in about 19% versus 19.6 versus 19.7%. So mild HIE, we know it causes problem in the future for these babies, but when they are cooled in these different trials, they found no difference between mild cooled and mild non-cooled. And you can see that the pooled estimate was just at the 1, and there was no difference between the two arms of the studies. But this is a pooled babies from different trials, not one single trial meant to cool mild hypothermia. So the answer, I think, for this, we don't know, and I don't think we should offer it yet to a premature babies, to a full-term babies with definite mild HIE, and a study needed to be done, or studies needed to be done to address this question. Would I cool a premature full-term baby with mild HIE? I look at different parameters, which we will discuss in the future, to say yes, I would cool them, or no, I would just say we don't have the evidence yet.
Okay, so they say bigger is better. So if this is really beneficial, so can we go lower than 33.5 or longer duration to cool them? Especially some patients, they don't improve immediately in the first 72 hours.
Right. Yeah, is deeper better? Is longer better? This was addressed and answered nicely in a trial which was called Optimizing Cooling Study. This was published by Shankaran in the JAMA in 2017, and they they wanted to look at cooling babies longer with the normal target temperature of 33.5, but 120 hours. Not 72 hours, which is suggested. So targeted temperature is 33.5, but longer, compared to 33.5, which is suggested, 72 hours. This is one part of the study. The other part of the study is looking at deeper hypothermia, 32 degree versus 33.5. Again, 72 hours versus 120 hours. And they looked at these babies with a primary outcome of death or significant neurodevelopmental delay at 18 to 22 weeks of life. They screened about more than 1,200 babies, and then they end up having about 90 babies in each limb of the study. Normal temperature, normal length, 72 hours. Sorry for the text is small. Normal temperature, but longer duration, 120 hours. Normal temperature, deeper temperature, normal time, 72 hours. Deeper temperature and long duration, 120 hours. They stopped the trial for safety reasons, because there was increased mortality rates in the limb of the study with deeper cooling and prolonged cooling. And they analyzed their data, and they found that there is a fatality from increasing the study beyond that number of patients they recruited. They recruited 364 babies. They meant to recruit more than 700 babies. And when they looked at their study, they found there is no difference in the outcome apart from mortality, whether you cool baby 72 hours, 33.5, or 72 hours, 32 degrees, versus cooling them longer time, 120 hours, both with 32 versus 33.5. The outcome was similar between all the groups, about 31% in all the 4 groups. So deeper cooling, longer cooling has no benefit. And the suggested cooling for 33.5 for 72 hours stand to be the recommended protocol for now.
Very disappointing, but it's good to know. So how about stopping the intervention earlier than 72 hours? Because, you know, sometimes we come to the round, either we discover the patient does not really qualify, or he has side effect, or patients improve. So what should we do during this time?
Okay. I will answer the second part of the question first. The second part of the study was the contraindication for starting or continuation of therapy. I think most of the people agree that, and that's from the different trial protocols, that respiratory failure with FiO2 of more than 0.8 or 80% of oxygen requirement, significant hemodynamic instability, and significant coagulopathies are the reason not to start cooling or to stop it if you started it. I faced some babies who we start cooling them, then they develop PPHN and they start needing more oxygen. A temporary raise the temperature to 35 to 36, and try to fix their PPHN as quickly as possible with respiratory support. And in the moment we feel that they are in a reasonable FiO2, we reinitiate the hypothermia again. This not being studied, but if it is studied and in the different trials showed that hypothermia works in these babies, then a gap of a few hours hopefully will allow us to get the benefit of the cooling and not to push the baby in a refractory pulmonary hypertension. But this is not being studied and it will be difficult to study this kind of babies because babies who have pulmonary hypertension and need cooling will be very, very few babies. So to get a study going with a significant number of babies would be somewhat difficult to do and it will take a long time. The other part of the question, which is, do you stop the baby improve before finishing 72 hours? Personally, I tell my people, no, don't. Because this baby qualified, continue for 72 hours. All the trial which was done, and we know hypothermia helped these babies, they didn't stop cooling if the baby improved. So if you start cooling and the baby qualified by a protocol, no, don't till you finish 72 hours of cooling. But that's my personal opinion, and there is no study looking at baby who improve, stop cooling, and compare them with the baby who continued for 72 hours.
All right, so I think a very practical question is that sometimes some of those babies are not intubated and they are fully awake. Although they qualify at the beginning, then the next day they start crying, asking for food. So those, what should we do? Should we feed them during the induced hypothermia?
Yeah, that's a good question because we face this all the time. Most of these babies are not intubated. Most of these babies are active, especially in second day after cooling. And they start crying and they are upset. And you don't know whether they are crying because they are hungry or they are crying because of the cooling and they are reacting to that. You give a baby pacifier and he sleeps and he becomes quiet. So it looks like maybe he's hungry, maybe. This is not being studied in a randomized controlled fashion. But people try to address this question in many studies. In the TOBI trial and the NICHE trial, they kept baby NPO by protocol because they were worried about gut compromise from the hypoxia and ischemia and the risk of necrotizing electrolytis. So they didn't feed their babies. There was a small reports from Scandinavian countries. They give their babies small amount of feeding during cooling. But it is a very small controlled amount. And they continue throughout the process of cooling. Thiersen reported in one of her reviews that low volume non-nutritive enteral feeding has been described. Maybe it's okay, but again, there is no study to address this question. As Abardi reported, a small number of a number of babies, he cooled them and fed them at the same time, and they found that 51% of the baby who were fed during the hypothermia reached full feeding by 9 days. Some of them reached full feeding by 4 days, just at the end of the cooling, and they had no major side effects with necrotizing enterocolitis or other GI problems. This is another study which looked at a comparison between the practice in Sweden and the practice in the UK. The UK, they don't feed their babies when they are cooled. The Sweden, they feed their babies when they are cooled. And they found that in the Sweden group, there was no necrotizing enterocolitis occurred. And in the UK study, babies reach full feed later than the Sweden group, and they said minimal enteral feeding during the cooling period may be justified, maybe doesn't have a significant complication. And though it did not increase the number of babies who reach full feed compared with the UK, and didn't shorten the stay in the hospital. So is it well studied? No. Do we have a definite answer to this question? Do we feed babies during cooling? There is no evidence to suggest whether to feed or not to feed. Personally, I feed some babies if they are really, really hungry and I feel that they are crying because of hunger. And I feed them a small amount, 10 mils every 3 hours, controlled, observe them carefully. And that's a practice which is not evidence-based. But there is no evidence to follow.
Just outside this question, and when do you feed them after you stop the after you stop the hypothermia?
We put them in ad-lib feed the moment they are warmed up. Okay. When they finish the 4 to 6 hours of warming up, and they reach normal temperature, we tell the nurse just feed them ad-lib, don't push them, but feed them. And most of the baby they feed very well, except the baby who are very, very bad. I have a baby now who's very bad, and we called him, and he wasn't willing to feed orally, and he's still on NG feeding or OGT feeding. Okay. So the good babies, the baby who improved, they feed quickly. And it is a demand feeding. The baby will tell you, yes, I am okay, I want to feed. When your stomach is full and you have a heavy meal, you wouldn't eat after 1 or 2 hours. You feel that you're okay. A baby who's good and his stomach is good, he will demand feeding, or she will demand feeding.
Because of the sake of time, we'll have to go fast. They are telling me the.
Okay, another couple of.
So do we have to use the cerebral function monitoring before starting or during the hypothermia?
All right, we'll try to go quickly. Now we know for sure that amplitude integrated EEG give us an insight in this baby's brain better than physical examination alone. Reports from Spitzmiller found that the sensitivity of amplitude integrated EEG in predicting long-term neurodevelopmental outcome, the sensitivity reached almost 90%, all right, and the negative likelihood ratio of 0.09. So it helps to predict future babies with some limitation. We cannot say it is the tool, but it's better than our physical exam alone. And you can see the pooled estimate of these different studies. Sorry for the text being small, but that's a cut and paste. You can see that the sensitivity is very close to 90%, and the specificity is closer to 85%. So this amplitude integrated EEG helps you to a certain extent to know how bad is this baby's brain. And I will show you some example. This is a baby whom, I like this example because it's really, this is a scenario of a baby. Same baby, this is 4 tracing from the same baby at King Khalid University Hospital. This is a baby who came, was very suppressed brain, has a birth suppression pattern, all right? This is at the time of starting cooling. After a few hours of cooling, 3-4 hours, he started to have better activity, more electricity in his brain. About 9 hours of cooling, he started to have a better tracing, a discontinuous pattern versus burst suppression initially, all right? And then at the end of the cooling, he had the normal tracing. So what made this baby to go from this bad tracing, which is on the up left, to a good tracing at the bottom of the right, is cooling. All right, so this baby shows us an improvement in his electrical activity by the brains. We know also that, this is from pediatrics, that abnormal exam alone has very poor positive predictive value. Abnormal EEG, it gives you a better positive predictive value and a good negative predictive value. And if you combine your amplitude integrated EEG with the exam, then you have very good predictive value, positive predictive value, and negative predictive value. So I like it, I recommend it, I use it all the time in babies who are subjected to HIE, even if they are mild. I say there is no way to know if this baby 100% mild unless you see his brain's electrical activity, and it helps us to say with a stronger heart, no, don't cool this baby, because he is mild, he behaves reasonably okay, though he is biting when you're allowing him to suck. He doesn't really suck, he's biting your finger, but his brains are good. He's normal, with normal activity, normal background, normal sleep cycling, a normal symmetrical activity. So yeah, don't cool him, he's good. But definitely it's not 100%, but it improves our diagnosis ability, and it's a good diagnostic tool.
I think because of we have only 2 minutes, can you share with us your personal experience? Because
all right,
Dr. Kharfi, one of the first people in the country.
What we do in King Khalid, we cool in the DR. We don't cool, but we switch the warmer off. So if you were called for a baby with bradycardia or a prolapse cord, or a baby who had a thick meconium and non-reassuring CTG, we tell our team, don't you, and he's a full term, we're talking about full term babies, don't switch your warmer on, all right? Resuscitate him without warming him up. Then we take him to the NICU without, again, heat. And then in the NICU, we quickly evaluate him, we put the brains on, and then within half an hour, we decide yes to cool him or not, or start warming him up to the normal range. That's what we do. I will go through, we don't have time for the passive cooling, and also for this is our published data, the simplified method of head cooling, which was published in Journal of Neonatal Perinatal Medicine. And in this study, we showed that using a simplified method of cooling, cooled babies reasonably well, kept them in the target temperature most of the time, all right, without sophisticated machinery. This also been used in the ICE trial. The ICE trial, which is one of the big multi-center randomized control trial in the cooling, total body or whole body hypothermia, used non-sophisticated method of cooling. They used the ice pack or the cool aid, the one you use when you have trauma on your knee or something. And they put it under the baby and they cooled the baby, and they found that most of the time the baby was in the target range of the temperature. What do you need to cool? Don't delay cooling in your center because you don't have the machinery for the cooling. It's better to have the machinery, it's more controlled, but there is trial to support cooling without machinery. All right? What do you need to be safe is a rectal temperature. If you have a continuous measurement of rectal temperature by rectal probe, then you will not allow your baby to go less than 33 and not more than 34. We keep them 33 to 34, and it is very easy to accomplish with a simple method of cooling. I will show you our way of doing it in King Khalid. We started on the right, on the left upper one. We start with head cooling. This is the baby. We head cooled him, putting ice packs around his head. He developed pulmonary hypertension. We put him in nitric and high frequency, and we cool him. This is the way we did it in the beginning, around 2000 or 1999. Later on, with the trial of NICHD come and said whole body hypothermia is better. So we said, we don't have the machinery, and we know this helped the babies to cool them down. Shall we stop and not doing it because we don't have the machinery? No. We have a rectal probe. We put the rectal probe. We take gloves, the disposable gloves, non-sterile. We fill them halfway with water. We put it in the fridge, and we keep it below the baby and around the baby. Rectal temperature on all the time, all the time. Nurses know to add gloves when the temperature starts to reach 34, and to remove gloves when the temperature starts to reach 33. And they keep it between 33 to 34. Simple. Then we became more sophisticated, and we start using the ice trial technique, which is in the top of the right side, putting a gel of cooling pads below the baby, covering it with a sheet, and putting it below the baby with a rectal probe attached to the monitor, continuously monitoring the baby. We did it. We published our data. We kept the baby in the target most of the time. More than 75 to 80%, our target was kept. Then recently, or for the last few years, we have, as most of the people, we have the cooling machine. It is servo-controlled, and it's easier for us, it's easier for the nurses, but it did not stop us from cooling babies before we received it. So please, don't stop cooling because you don't have the machines. It's been published. The ICE trial, a big trial, did it without machines, without servo-controlled machine. What do you need? Rectal temperature monitoring continuous. And a nurse in the bedside knows what to do when the temperature goes up or down. But please do it, because we know for sure that cooling makes babies better.
Yeah. Okay.
All right, so I will stop here. There is more other things, but we don't have time. So, thank you.
Okay. Thank you very much, Professor Turki, Dr. Adel, Dr. Zakaria.
Yeah, we can allow 2 questions. I know it's very, we are late for the lunch, but we allow very short 2 questions. And we'll have some announcement. Maybe I will start while the people is thinking. So, Dr. Prof. Al-Kharfi, what about cooling a baby outside the delivery room, in ICU or normal nursery?
All right. I addressed that in my speech. We don't cool them in King Khalid. We don't cool them in the first hospital. We don't cool them in the DR. Or during the transport?
No, it's after 24 hours. Full-term baby in the NICU, bilirubin, extubated. They could not intubate, resuscitate for 20 minutes, sustained hypoxia. So did you cool this patient or no?
I don't. The evidence is not available. The only evidence we have from 6 to 24 hours, the optimizing cooling, the Shankran late hypothermia trial, suggested that after 6 hours, cooling was not of help, though there was a trend towards improvement in the cooled part, but the evidence is not available, and I don't usually cool these babies.
Okay.
Sometimes the PICU people call us.
Actually, in ICU, some people they cool because you know the event, the timing of the insults. So still you can count 6 hours of that.
That's different question. That's different. If the baby is insulted within 6 hours, he was insulted 2 hours, 3 hours ago, then I think the protocol is still applied. A baby who is insulted, whether from birth due to hypoxia during the delivery process, or in the NICU development, I would call him, definitely. This is different,
Dr. Jamil?
Thanks, Prof. Turki. My question to you, using of adjuvant therapy with the hypothermia like erythropoietin, xenon, magnesium sulfate. And the other question, the acceptable heart rate with the hypothermia, because with the hypothermia, some of the baby heart rate it will went down up to 70. What is the acceptable heart rate you are accepting in hypothermia?
All right, both are good questions. The first question, I have some slide to address, but because of the shortness of time, lack of time. Now, we know from the multiple trials, from the randomized control trials and the meta-analysis of these trials, that when you have a baby with moderate to severe HIE, cooling them improve their outcome in about 50% of the cases. Still, we have about 45 to 50% of the patient, they don't improve. Whether it is the severity of their insult, whether it is the pathophysiology in this specific brain of this baby, but definitely cooling babies does not make every baby normal and save the baby. So there's got to be something else. We know from the recent literature that there is not only 3 stages of asphyxia, like before we see HIE, the primary, secondary, and tertiary. Now there is also a 4th stage. This 4th stage goes on for weeks and months. More of inflammation of the brain. All right, more of apoptosis of the brain, which is continuing for a long time. So going and interfering for 3 days or 72 hours does not stop the brain continuing suffering from the insult you received. And people looking into adjunctive therapies to improve the outcome of the other 40 to 50% of babies who didn't improve with cooling alone. The list is wide. Very big list. Erythropoietin, there is a trial from the Chinese trial. Erythropoietin alone showed improvement in the neurodevelopmental outcome and the primary outcome of these babies and the mortality. But hypothermia plus other adjunctive therapy like xenon, elebrenone, erythropoietin, topromate as anticonvulsant, it's been also used, phenobarb, they are not yet addressed well to make a conclusion. But I think there will be a place for this intervention in the future because hypothermia alone, only 50 to 60% improve. The other part, the heart rate, yeah, we allow them to go as low as 80. If the blood pressure is okay, we don't bother with the heart rate. We know it goes down. Most of the baby will be between 80 and 100, and they improve as you warm up. If the blood pressure is normal, urine output is okay, blood gas is okay, acid-base balance, we don't bother with the heart rate.
Okay, last question, female side.
Another question about this magnesium sulfate. When you are using this in magnesium sulfate.
Sorry?
Use of magnesium sulfate.
The use of magnesium sulfate. Yeah, the magnesium, I don't know who's talking. That's why I'm searching for the person who's asking the question. Magnesium sulfate, even it's being done, there was a feasibility trial combining erythropoietin, magnesium sulfate, and cooling. This feasibility trial used 1,000 units of erythropoietin plus the hypothermia plus magnesium sulfate, I think was 100 milligram dosing, and showed that this is feasible, that there is no long-term collapse, and the number was small, about 9 babies in each arm of the study, so we cannot really make a conclusion out of that. Magnesium sulfate being used alone in a study which is ongoing to see whether magnesium sulfate by itself will improve the outcome of the neurodevelopmental outcome and mortality and survival rate of these babies, but the result is still waiting. Actually, I think it could be another thing which could be added to magnesium. Magnesium plus erythropoietin. The future is still to tell us what to do with these babies.
Because of really time and people so hungry, we would like to thank all our speakers, and we will have an announcement from.
I guess I made a copy. Copies are there for anybody who's interested for our KTH protocol for hypothermia.
Yeah, it's in the front, the survey.
Yeah, it's very summarized protocol, and it is published also. Thank you, Professor. Speak it up, please. Thank you. But the organizing committee, please don't go away because we have important announcement. Number one, we would like to thank you being late a little bit on your lunch, and we want you to come back before 2 o'clock. So when you go for your break, keep that in mind. Number two, for Dr. Kharfi, as chairman of Saudi Neonatal Society, he was the first chairman and president of Saudi Neonatal Society, and he is the, with the team at that time, he's the people that started. So we would like, to recognize his effort, and we want him, to take a simple gift from the society.
Dr. Ibrahim Al-Hifzi, he will hand it to Professor Turki, and we wish him all the best. And maybe we should, wait for him in the future to be having another term. You will not go again once more time? Abu Muhammad, you don't go again one time more in the society? أنا من فوق أشوفكم.
يعطيكم العافية بس اوكي. خلاص, we'll see you inshallah after you have your lunch and prayer break, and thank you for being with us. Don't forget, we have interesting session afternoon for the research abstract, and there will be winning research, so be with us and see who will be the winning for this year. Thank you. الله يعطيك العافية. الموضوع يعني very important صراحة. الدكتور جمال عطا يا حبيبي تعال. طيب. Assalamu alaikum. Welcome back to the last session of the meeting, which related to the research and research presentation. It was 7 presentations, and we have 1 apology because of the flight time, so we are down to 6. And we will start now and soon, and we'll start with Dr. Jamal Ata. Please, Dr. Jamal, 8 minutes. Go ahead.
Okay. Bismillah ar-Rahman ar-Rahim. I would like firstly to thank the organizing committee to give me the opportunity to present my study. It is about the efficacy and safety of delayed umbilical cord clamping compared to umbilical cord milking in preterm infants. It is a randomized control trial. The current evidence suggests placental transfusion through delayed cord clamping for at least 30 to 60 seconds for most of vigorous term and preterm in newborns. Even WHO recommending at least 60 seconds for DCC. Moreover, the placental transfusion can be achieved safely by doing umbilical cord milking for both term and preterm babies. Why UCM? Because DCC might interfere with the resuscitative measures, and on the other side, the milking of the umbilical cord is done at a faster and shorter time, which will make the obstetrician more convenient to apply it if it's considered as standard of care at delivery room. Even the newer evidence for UCM compared to DCC showed higher initial hemoglobin, blood pressure, and systemic blood flow, but no conclusive evidence for the long-term neurodevelopmental outcome. However, till now, UCM is not recommended as a standard of care for the management of the neonate at delivery rooms. The aim of our study to compare the efficacy and safety of UCM to DCC in preterm infants less than 32 weeks of gestational age. Our study approved by the Biomedical Ethical Committee at King Abdulaziz University Hospital and registered at clinical trials as well. As I mentioned, it is RCT, and we involved the preterm babies from 24 weeks up to 31 plus 6, and we excluded others with congenital anomalies, placenta previa, abruptio placenta, cord prolapse, RH sensitization and fetal hydrops, monochorionic multiples, and ER delivery and unbooked ladies, and even some in the maternal infection like HIV and the hepatitis B and C. We allocated our infant to 2 arms. One of them DCC group, and the other one is UCM group. For DCC group, the neonate is held at the level of the placenta. For vaginal delivery, at the level of the introitus, and for CS deliveries, at the level of mother's thighs or operating tables. And later, cord clamping is deferred for 60 seconds. For UCM group, we are doing this intervention by manually stripping 20 centimeters of the cord towards the umbilicus over 2 to 3 seconds for 3 times before cord clamping. For randomization and allocation, computer-generated random table list was used and was kept confidential to the investigator. We allocated randomly to UCM and the DCC, and sequentially numbered oblique sealed envelopes with allocated intervention was opened by the head nurse in delivery room. Once the eligibility was determined and the informed consent was taken. For blinding, we couldn't blind this intervention for the obstetrician and the delivery room nurses because it's the nature of this intervention, of course. But we blinded it for the all health care provider in NICUs. The outcomes, we have primary and secondary outcome. The primary outcome is intraventricular hemorrhage. Secondary outcomes are neonatal and maternal outcomes. For neonatal outcomes, management in delivery room, hematological values, respiratory, cardiovascular, and neurological and gastrointestinal outcomes as well. But the time will not serve to mention all in details. For maternal outcomes, for postmortem hemorrhage, length of the third stage, and the need for manual removal of the placenta. Statistical analysis, we determined a sample size of 180 infants to get at least more than 20% difference between the two groups. And the statistical methods, we used appropriate statistical methods to describe and to compare between the two groups, and the intentional to treat analysis was applied as well. For the result, we did interim analysis for the time being, and we have 101 infants. 40 of them were excluded because 9 of them not meeting the inclusion criteria, and 11 declined to participate. 20 exceeded 32 weeks gestational age. The remaining 61 allocated either to the UCM or DCC group. For UCM, we have 30 patients. 29 of them received the intervention. 1 of them didn't receive the intervention. The obstetrician didn't do it. And for the other DCC groups, 29 received the intervention, 2 didn't receive intervention because 1 was unstable and the other one inside the sac, and no one lost for the follow-up, and all results were analyzed till the time being. For the result, maternal and infant characteristics, we didn't find significant difference between the two groups, but we insisted to keep the p-value in this table to be sure from the comparability of the two groups till the end of the study. For maternal outcome, we didn't find significant difference between the two groups as regarding the items I mentioned before. For neonatal outcome, as regarding management in delivery room, need for intubation, chest compression, hypothermia, no significant statistical difference between the two groups, but you can see there is 2 babies from the UCM group developed hypothermia in comparison with 7 babies in the other groups. For the other neonatal outcomes, hematological parameters, and even the need for blood transfusion, we didn't find significant difference between the two groups. For the other neonatal outcomes, what I meant, the prematurity-related morbidities and even the mortality rate, no significant difference between the two groups, but you can see from 2 of the UCM group developed the neck in comparison with 7 in the DCC group. In conclusion, no differences in the maternal and the infant outcomes between the two groups, and no increased harm was established at this point while applying the UCM. The strength point is randomized control trial, and the blinding for healthcare providers in NICU, and the complete follow-up for all the patients. The limitation in our study, the cooperation of obstetrician, 1 of each arm didn't receive the intervention. And on the other point, the result of the study cannot be applied to the infant excluded, what's called external validity. At the end, I would like to thank all of you for your attention, and special thanks for the delivery room team, NICU team, and of course to my
Thank you, Dr. Atta. Thank you, Dr. Atta.
Thank you.
We can allow 2 quick questions. Somebody ready to ask question? Dr. Hifli? Anybody? Colleague? Dr. Kielani? Any one of you, but Kielani, go ahead.
Yeah, my question about the number assigned when you do the statistical analysis, you didn't tell us what outcome you're looking for, on which basis you calculated the numbers for the power.
Okay.
Which is very critical, I think, in this.
Based on the previous study, and the epidemiologist is the one insisted to, she calculated this number to get at least more than 20% difference between the two groups, to get a significant difference or not, according to this. It's calculated issue, yeah.
What is the measurement?
Yeah,
Doctor, what is the measurement you are
what's the
asking for?
outcome that you...
What is the outcome looking for?
The primary outcome that the power calculation were based on, is it the IVH, is it the PDA, is it combined?
The primary outcome, intraventricular hemorrhage.
Intraventricular hemorrhage?
Yeah.
Okay.
Okay, any other question? Quick one, yeah, Dr. Alayan?
Yeah, I think well designed, but I consider it as a negative study.
Negative?
Yeah, it's a negative study. There's no difference between the two in terms of the IVH, right? Were you expecting to see a difference or no?
But we expected, we hoped to be a better outcome. But even the main barrier to implement it is the obstetrician and even the other teams. They are worried to spend a lot of time with DCC. So that's why we are doing it.
My question: do you expect to see differences in IVH between the two methods?
By the way, the placental transfusion and the meta-analysis done for the other studies for term babies, there is a significant reduction in IVH, so that we hope also to get this.
Okay, this is why your study is negative. Why it is negative? Maybe because when you calculated your sample size, they were like 180, and they reduced to 30 in each arm, right? So maybe because of small size, you couldn't get what you want.
This is one point, but we didn't finish yet the whole study. It is an interim analysis for 1/3 of the total.
Halas, I think we are enough in the discussion. Can we go to the next, presentation by Dr. Shadi Nu'man? He will present about fluid supplementation in preterm infant with unconjugated hyperbilirubinemia. Dr. Nu'man.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. I would like to thank the scientific committee and the chairperson and the audience for giving me this opportunity.
Okay, so your ear is, which one is?
Shadi.
We are not counting the time now. We are not counting the time, so we'll give you a few seconds, okay?
I'm going to talk about the effect of increasing fluid supplementation during conventional phototherapy in preterm infant. I will go through background, aim of study, methods, results, conclusion, strength, and limitation. Hyperbilirubinemia is one of the most frequent problems in the neonatal period, especially in the preterm infant. And the phototherapy remains the treatment of choice for that. As we know, the preterm infants, especially in the first few days of life, they have physiological instability, immaturity of their organ, large surface area, which lead to increase of insensible water loss. The former data was proposed that an increase in insensible water loss in preterm infant who is exposing to phototherapy up to 20%. Even if you are controlling the temperature and humidity of your baby. While the other study was that showing no need to increase the fluid supplementation during phototherapy as long as you are controlling temperature, humidity, and monitoring the output of your baby. In more study 2008, the impaired preterm survivor and survivor with hearing loss was significantly higher peak bilirubin level compared to an impaired survivor. Moreover, the restriction of fluid supplementation, especially in the first few days in the preterm infant, had significantly reduced the patent ductus arteriosus and NIC, with also trend toward decreasing of bronchopulmonary dysplasia, IVH, and mortality. So, because of the paucity of data or evidence in preterm infant regarding the effect of increasing fluid supplementation during conventional phototherapy, we aim to assess the risk and benefit the risk and benefit of fluid supplementation compared to standard fluid management in preterm infant 28 to 32 weeker gestational age who required phototherapy for indirect hyperbilirubinemia. We studied that in an exploratory pilot retrospective study. I consider it as a pilot study because it has not been studied before. We study all preterm infant 28 to 32 weeker who was admitted to MCH Hospital Jeddah over a period of 18 months from June 2017 to December 2018, and I get my ethical approval through the Research Center of MOH. This is a copy of the approval. My primary outcome was the rate of decline in serum bilirubin level after the starting of phototherapy, and secondary outcomes were duration of phototherapy, a change in creatinine, sodium, weight during phototherapy, incidence of prematurity-related comorbidity like PTA, IVH, and bronchopulmonary dysplasia. Lastly, the rebound hyperbilirubinemia. We include all preterm infant 28 to 32 weeker who require the initiation of phototherapy in the first week of life, according to the NICE guideline. And we exclude all the infant who has major congenital anomaly, pathological jaundice, direct hyperbilirubinemia, bilirubin level in exchange transfusion, and any morbidity that need restriction of IV fluid like heart failure, significant PDA, neonatal depression, or encephalopathy. Our NICU guidelines in the MCH, we are starting the preterm infant by 80 cc per kg per day, and we are increasing 20 cc per kg per day based on the weight, serum sodium, fluid deficit, and urine output. The phototherapy was started according to the NICE guideline. We are using the MediPrima machine, which contains 6 fluorescent blue tubes with a wavelength of 450 to 460 nanometer with a radiance of 3.7 per hood. And the phototherapy was placed on the top of an incubator or tilted to side if needed for double phototherapy. This is our MediPrima machine we are using. The infant were kept on the supine position and uncovered for maximum light exposure. Opaque eye patch covering the eye, or surgical mask or small diaper covering the genital area. And we are collecting serum bilirubin every 12 to 24 hours according to case. Double phototherapy, it will be started if serum bilirubin more than 8.5 millimole per liter per hour, serum bilirubin level within 50 millimole of exchange transfusion, or not responding to single phototherapy. And we are weaning the phototherapy if 50 millimole below the phototherapy according to NICE guidelines. This the sample size, as we said before, from 28 to 32 weekers consecutively over a period of 18 months who meet the conclusion criteria. We use an appropriate statistical test, and p-value of 0.05 were considered statistically significant. Now, we are recorded more than 176 cases. 115 was eligible for the study over this period. As we see here, 64 patients were receiving extra fluid supplementation, and 51 was receiving the standard fluid supplementation. There was no significant difference in gestational age, birth weight, gender distribution, or using of double phototherapy between two groups. This one, the demographic data. With regards to our outcomes, as we see here, there was significant difference in duration of phototherapy. Okay. There was significant difference in duration of phototherapy between two groups in the extra fluid supplementation versus standard fluid supplementation, with p-value of less than 0.01 in the extra fluid supplementation group. Also, the rate of decline was more rapid in the extra fluid supplemented group versus the standard fluid supplemented group, with the p-value also less than 0.01. There was no significant difference in sodium level, creatinine change also during phototherapy, weight change also, and rebound hyperbilirubinemia. Also, there was no significant difference in the risk of comorbidity like IVH, PDA, and chronic lung disease, although as we see here, the IVH was happening for 7 cases in extra fluid supplemented group. 5 of them was grade 1 and 2 was grade 2 versus 6 cases in standard fluid group. 5 of them was grade 1 and 1 was grade 2. In conclusion, fluid supplementation preterm infant 28 to 32 weeker with unconjugated hyperbilirubinemia who required phototherapy significantly decreased the serum bilirubin level and total duration of phototherapy with no impact or risk of morbidity or need for exchange transfusion. Strength of our study was inclusion of all eligible infants in the study period to minimize the selection bias, and the collection of the data done by one research member to minimize also the informational bias. Our limitation being a retrospective, and study is not powered to detect difference of small magnitude, as I mentioned before, because it has not been studied before, so difficult to calculate the sample size, but definitely it will guide us for further larger scale of future randomized control trial in preterm infant to assess the short and long term outcome of fluid supplementation with conventional phototherapy in preterm infant. And finally, again and again, I would like to thank the scientific committee or the audience and the organizer for giving us this chance. Thank you.
شكرا يا دكتور. 2 questions. أيوة دكتور عيسى تفضل.
Thank you very much. What type of phototherapy have been used? Is it lead technology or without lead technology?
Not lead technology. This is the MediPrima machine, the old one that are using that show the picture here. The old one, the MediPrima machine. We are not, still, I didn't do any research about that.
Thank you, Shadi. Try to make your answer quick. Okay. Go ahead.
Thank you, Dr. Shadi. How you make sure that there is good separation between the 2 groups, like the standard fluid and the supplement?
Yes, we are writing this one in the order sheet, that standard fluid supplementation. For extra fluid supplementation, we are writing the increasing. We consider, according to the Cochrane protocol, of increasing from 15% to 25% is our target or our extra fluid supplementation in that one, and we are registered in the chart for the baby.
Thank you. Any other question?
Can I just, you know, when you say single, double, triple, whatever, I mean, these are not really recommended. The AAP recommends to measure the intensity. Without measuring the intensity, you know, using phototherapy don't mean anything.
Sorry, doctor, again? The intensity of?
The intensity of the light.
Yes.
Reaching the baby. That's the most important thing. Yes. What's recommended, it should be 30 and more. That's what's recommended by the AAP. If you say double or single or triple, doesn't mean anything.
Yes, regarding to the intensity, all of the phototherapy are putting on the top of the incubator, and the irradiance, this one, the one of the effective for the baby, the irradiance was according to MediPrima machine.
Did you measure the intensity at the level of the baby?
No, the irradiance was 24.
So if you don't measure the intensity, you cannot say that they are all equal. So it's very difficult to say they're all equal.
The machine was same, but
thank you. Thank you. Enough, Shadi. Thank you. We'll go to the next presentation, and it will be done by Nadia Al-Harbi. Somebody help her to put the doctor. Somebody help her to put the presentation on to save some time. Dr. Nadia Al-Harbi will talk about the burden of unjustified admission to NICU. Burden afternoon. So, go ahead.
This is yours? Yeah, so waiting.
يعني.
Okay. Hold on. Okay. طيب بسم الله. هذا hold on. بسم الله.
Assalamu alaikum wa rahmatullah. I want to thank the scientific committee for choosing my research. My research is about the burden of unjustified admission to the NICU. The intensive care unit provide life support for neonate. However, unjustified admission to the NICU enter risk for both family and their admitted infant, including high cost. Admission to the NICU interrupting mother-infant bond and establish breastfeeding, which is so crucial in the early postnatal period. Our objective is we observe that many neonates admitted to the NICU outside of justification criteria. So in order to minimize unjustified admission, we aim to ascertain the prevalence and the causes of unjustified admission of the neonate, more than 18,000 grammar to the NICU in Medina Maternity Children's Hospital, in order to identify the central area to focus on and quality improvement strategy and the bed occupancy. We have clear admission criteria to the NICU, which is need for oxygen more than 40%, less than 1,400,000 grammar, gestational age less than 32 weeks, unstable vital signs, hemodynamically unstable baby, and life supporting equipment including CPAP, high frequency or mechanical ventilation, multiple organ failure, and life-threatening infection. Major surgery, major congenital anomaly, which required diagnosis or surgery. Central line insertion and exchange transfusion or required frequent stimulation for apnea. This is MOH target, which is in the first quadrant of 2017 was around 18% of our delivery is admitted to the NICU, which is high according to the MOH target. The patient and method. Retrospective chart review were conducted to the NICU and Medina and MCH for 18 months, from 1st January 2017 to 30 June 2018. Which is only maternity and children's hospital in Medina region with capacity of 84 NICU bed, 97% full occupied, and more than 15,000 delivery per year. We have more than 75% unbooked mother who didn't attend any prenatal clinic. The patient and method. This study proved by ethics committee. The admission book for NICU record were reviewed to determine the admission rate. It was around 3,811 patients as a total admission to this period assigned. Neonatal data were collected, electrical medical record and medical file from admission till discharge. The patient and method, the data including gestational age, sex, nationality, birth weight, anthropometric measurement, duration of the infant stay in the NICU, admission and discharge diagnosis, positive blood culture, respiratory need of respiratory support, maternal disease and medication, and mode of delivery. The prevalence of the admission was calculated by dividing number of unjustified admission to the NICU, more than 18,000 grammar to the NICU, by the total number of admissions in this period assigned. NICU conducting the plan of care to minimize unjustified admission to the NICU by providing care of mild cases who need observation and didn't fit for NICU criteria with their mother. We compare the baseline characteristic diagnosis and NICU cost in the period of the time to before and after this bundle. This bundle including care for these mild cases. We have clear criteria for the mild cases, including patient with the CS or mother in the gynae ICU, gestational age at least 35 weeks, good Apgar score, not in respiratory distress, infant with mild respiratory distress watching at least 1 to 2 hours in that bundle, and minor anomaly that need further investigation but not need infant, that didn't interfere with infant health. small gestational age and large gestational age, infant of diabetic mother with need monitoring blood glucose. Term infant more than 37 weeks with a BROM more than 18 weeks, and who was asymptomatic without respiratory, without history of chorioamnitis. We do CBC differential and IT ratio with blood culture. We observe for 48 hours. Infant with hyperbilirubinemia can be treated with single phototherapy. This infant followed by a physician and increasing in the nurse for dangerous sign and when next the physician. The result, the significant, the statistic analysis done by SPSS, and if the data, we use a chi-square test and Sherbo test, also the p-value more than 0.05 as a significant level for all statistic analysis. The total admission to the NICU in 18 months was 3,811. Around 78% was justified admission, including respiratory distress, neonatal jaundice, multiple congenital anomaly, and others. Unjustified admission, around 21%, which is our target. Most of them was BROM. This is baseline characteristic of unjustified admission. We divide it before using the bundle and after using the bundle. Before the bundle, we admit around 670 patients, and after the bundle, we admit around 144. No significant difference in the baseline characteristic, but there is difference in the total number and the total hospital cost. It was before the bundle around 1,200,000 riyals, and after the bundle 286,000 riyal, which is significantly decreased and more than 0.05 p-value. We compare these unjustified admission before using the bundle and after using bundle, which of these infants tend to be justified reason for admission. We admit around 448 patients with BROM. Only 19 patients tend to be justified from them. And after the bundle, 58 patients tend to be justified, only 5 patients. And we admit around feeding intolerance baby, 94 and 38, none of them tend to be justified reason for admission. About query metabolic disease, 43 patients admitted, 12 patients diagnosed with metabolic disease and follow up with metabolic consultant. Maternal disease and medication, minor surgical need, including minor surgery, not need immediate surgery, birth trauma patient, and other causes like polycythemia, fever, and all these, no patient tend to be justified reason, and none of them need respiratory support. Many cases who are admitted to the NICU unjustified reason, separating from the mother unnecessary anxiety and increase cost for medical care. We recommend that NICU have clear policy for admission and should restrict it for following this policy. The clinically stable infant with potential risk can be safely managed with their mother without need to an ICU. The strength, all the data is available and larger sample size. Limitation, retrospective study, and we are only studying the unjustified cases, not both. And this is MOH target. After we apply this bundle, we decrease from 18 in the first quadrant of the 2017 till 15, and at the end of the 2017 until 12.7 at first quadrant of 2018, which is fit for MOH target. This is my reference, and special thanks for Dr. Khalid Sidi, my supervisor, and Dr. Aziza, Dr. Nihad, and Dr. Islam, and Sister Rehab.
Thank you, Doctora. Thank you, Doctora Nadia. Dr. Zakaria.
Very excellent study. I'm worried about one thing. There you wrote the cost before and after, the p-value was not significant. So it's very strange that it's 0.09. When the magnitude, it's more than 1 million something, then it came to like 250,000. Can you comment about that?
This one?
Can you put the slide? The slide, please.
It will take time. Okay. Can you remember, Doctora?
Yeah. So this one around before the bundle, because the total admission of the patient was too much, around 670 patients. And this is the total cost for all the group, around 1,200,000. And after the bundle, because they decreased the number of admission, it's decreased to 268.
No, are you sure about the p-value 0.09 only?
So why the p-value is not significant? It's so big difference. Huh? The statistician maybe have a problem. Any other questions, please? Questions?
Go ahead. Regardless of the p-value, they save money, okay?
Wait, you don't.
And also save.
You don't believe in it.
Save so much anxiety for the mother and separation. I think this is a very good point, regardless what the cost is.
Okay. Excellent. Any
for per
quick
patient.
questions? Go ahead.
It seems that the p-value is calculated for per patient. The hospital cost per patient has not changed. It's just the total number. So probably that's what it refers to.
But economically, you should look for the whole picture.
Right, but I think that's probably where the mistake is.
Yeah, maybe.
Yeah.
Thank you. Any other quick question, or we move to the next one? I think we'll move, please. Thank you. Thank you, Dr. Nadia. So the next presentation will be by Dr. Farzin Muhtasham, and she will talk to you about the effect of tahniq with dates on hypoglycemia in newborn, randomized clinical trial. So we'll give you 8 minutes, Doctora, to talk about us to the hypoglycemia and tahniq.
Bismillahirrahmanirrahim. I'm going to present this study about the effect of tahniq with dates on hypoglycemia in newborn, which is the thin study. Introduction. Tahniq is an Arabic word which means putting something sweet, such as dates, in the infant's mouth after birth. It's a noble practice in Islam and is a recommended sunnah of our Prophet ﷺ, which is authenticated by various hadith. And it's done by rubbing a softened date or a date paste on the palate of the newborn after birth. And during the time of our Prophet, it used to be done before the milk feeds. Our postulated benefits for this is it exercises the muscles of the mouth, and hence it may help with breastfeeding. Dates, being rich in sucrose, could be effective for pain. As we know, sucrose is well known to reduce pain during various painful procedures, and tahniq may help to prevent hypoglycemia in newborn before the breastfeeding is established. We all know that the blood glucose falls in the first few hours after birth, and the incidence of hypoglycemia in the immediate postnatal period is about 5 to 15%, and even much higher in the high-risk group. And usually a level of 2.6 millimole is widely accepted. We heard this on day 1 from the speaker. And standard management is usually by establishing early breastfeeding within 30 minutes of birth. And if feeding alone doesn't help, then usually the babies need IV bolus of dextrose at 200 milligram per kg. But then this needs admission to the NICU, separation of the mother and the baby, delays the breastfeeding, apart from incurring high health care costs. Recently, there have been studies with the buccal gel, either as a treatment or prophylaxis, and it has proven to be reducing the incidence of both the hypoglycemia as well as NICU admission. So our study is based on the buccal gel study. Our aim is to assess the effectiveness of tahniq using dates compared to routine feeding practice on the blood glucose level among the at-risk newborn babies at our hospital in the first 48 hours after delivery. It's a single-center, open-label, randomized controlled trial. Our sample size is 324 with 162 in each arm, and this number is powered to detect a difference of 15% for the primary outcome, which is the hypoglycemia. Our PICO, The population is at-risk neonates. The intervention is technique with dates, giving equivalent glucose of 200 milligrams per kg. Control is routine feeding, and outcome is hypoglycemia, NICU admission, and other secondary outcomes. This is our ethical approval and our approved consent form, our international registration. The inclusion criteria are babies who are at risk of hypoglycemia, who are infant of diabetic mothers, mothers with any type of diabetes, late preterms, 34 to 36 plus 6 weeks, low birth weight less than 2.5 kg, and large for gestational age, which is more than 4 kg. Excluded babies are those with major congenital anomalies, including severe cleft lip and palate, babies who required immediate NICU admission for any reason, babies less than 34 weeks of age, and of course, if the parents refuse consent. Our primary outcome is hypoglycemia, defined as any blood sugar concentration either less than or equal to 2.6 in the millimoles per liter in the first 48 hours. And also the other one is admission to an ICU for hypoglycemia. Secondary outcomes are hyperglycemia, any blood glucose more than 10 millimoles per liter, breastfeeding at discharge from hospital, it might be either exclusive or partial, and again also at follow-up visits at 2, 6, and 18 months. Pain scale as measured by Cry scale, because that's the one used in our hospital routinely, and the developmental assessment at clinic visits. Intervention, all the babies are allocated either to the treatment or the control arm by sealed envelope randomization. In the study group, the babies are given a single dose of soft date paste, which is pre-packed by the pharmacy. That's the package, which is enclosed in these bottles and are kept in the nursery. And as soon as the baby is brought to the nursery, around 1 hour of age, and we make sure that the baby is stable, the intervention is given, and the other side control, the babies receive normal feeds as routine. The blood sugar is measured for all the study babies as per standard protocol, and in case of any hypoglycemia, again, the baby is managed as per protocol. That's our protocol that we follow at National Guard Hospital. And the heel prick is measured, during the heel prick, the pain scale is recorded by the nurses, and the data were analyzed by SPSS 25. This is the instruction to the nurses. And the video of a baby receiving the technique, we can see it's a simple procedure, just massage to the palate, and the baby, Coming to the results, we had 295 babies assessed for eligibility. We excluded 75, 2 were dysmorphic, 19 because of refusal to consent. 21 were missed, and 33 babies were immediately admitted to an ICU. So we had 220, 104 in the intervention arm and 116 in the control arm, and all of them were analyzed. Results, as we can see in the maternal demographics, we don't have any significant differences. The diabetic mothers were about 67 versus 64%, and 15 mothers out of those in the technique group, and 13 on the other side were on medications for their diabetes. For the neonatal demographics, the gestational age was around 38 weeks, no difference. Birth weight, again, around 3 kg, no difference. The small for gestational age babies were 26% versus 35%, slightly more on the control side, but the group p-value was 0.4, so no difference. The sex, again, was not different, exactly 50% in the technique group, and the Apgar score as well, not significant differences. The outcome, we had 11 babies who had hypoglycemia in the technique group and 16 in the control group, but the p-value was not different. The NICU admission due to any cause was 5 babies in each group, but the NICU admission for hypoglycemia per se was 1 baby in the technique group versus 3 babies in the control group. The exclusive formula, exclusive breastfeeding at discharge was only 6 babies in the technique group and 3 in the control group, and formula feeding, unfortunately, very high in this group. In this study, 18.2 in the technique versus 20, again, no difference in the p-value. Most of the babies were discharged within 2 days on both sides, and the pain score was not different on both sides. Regarding the babies with hypoglycemia, we had more babies with GDM in the technique group and more with IUGR in the control group. The hourly blood sugar values were not much different, but they were trending to be on the highest side on the technique group, but no significant differences. So in conclusion, the interim analysis of this study showed no statistical difference in the incidence of hypoglycemia, nor in the incidence of an ICU admission, but there were more babies with hypoglycemia and also more admissions secondary to hypoglycemia in the control group. Technique with dates is safe, feasible, and culturally acceptable, inexpensive, it's non-invasive, readily available. We had no adverse effects whatsoever during the study group. There was no incidence of choking, infection, hyperglycemia. The highest blood sugar we had was 6.2 and 6.4, and no rebound hypoglycemia. So we are waiting for the final results of this study. Limitations are for us were the paucity of the data of technique and its effects on the newborn is unblinded because of the procedure itself, single center, and the high use of formula feeds in a hospital setting might have masked the true incidence of hypoglycemia, and of course most of them were infant of diabetic mothers.
يكفي دكتورة. Thank you. Thanks. Thank you, Doctora, and floor open for questions. I will start with you with this question. What about this dates you are using? Did you measure the glucose content accurately? Because different dates have different glucose compared to sucrose.
Yes, tell them to put the slide. Yes.
On the slide, please.
Can we have the slide, please? We have a study which is conducted about the different types of dates were analyzed, almost 29 varieties from Saudi Arabia.
Put the slide on, please.
And this is the slide. So this is Sukkari al-Qasim. We decided to take Sukkari for 2 reasons. One, it's easily available. It's also available as a plain date paste and without being mixed with the others. Plus, the fructose content in this slide, in the Sukkari, is the lowest that we found.
Excellent. So you look at it. Thank you. Any other question? Dr. Alayan.
Yeah. Can you guarantee that these babies will swallow the date? Because you just put it there. I mean, it may stick to their palate and that's it. Then you don't guarantee that it goes down.
It's actually not swallowing, doctor. We are actually rubbing the palate of the tongue. It's being absorbed by the buccal mucosa. If you do it and you can feel it, the date paste is on our hand and we rub it for like 1 to 2 minutes. I did not pull the whole video, and actually we can make sure that there is no dates, neither in the baby's mouth nor in the finger. It's all absorbed.
Excellent. So there is a standardization for the technique of doing it. Any other question? Dr. Kailani.
Have you controlled for the amount?
The mic on, please.
Just press it once.
Have you controlled for the amount of date that is used each time?
Yes, doctor. I think in the instruction for the nurses, we had the instruction regarding how much to give for each. Each date packet was 400 milligrams. For a 2 kg baby, it's 1 packet. For a 4 kg, it's 2 packets. For a 3 kg, 1.5, with this clear instructions with the details given to the nurses.
Okay. Any other quick question? Please, Doctor, tafadhal. Put the mic on, please. Now, yes. Now you can talk.
Thank you, Doctor, for something that's new to us, actually. But I don't think it is logical if I'm working in level 3 or level 4 hospitals just to give this to the finger of the nurse and tell her, I don't know how much amount, and there are different types of dates, and I'm not sure whether the baby will absorb this, whether the baby will digest this, and what's the difference of giving honey, for example, or just...
طيب يا دكتور خلاص your idea reached. Any comment?
Honey has there is a possibility of botulism. So we avoided honey totally. Plus the sunnah, basically every sunnah that we read was with the dates.
شكرا يا دكتورة. Enough. I think it's enough. Your point is clear. Thank you. The next presenter, please. The fifth presentation.
Slide.
Yeah. So the fifth presentation will be by Hana Al-Muhammadi from Al-Madina, and she will talk about the risk factors and the predictors of rebound hyperbilirubinemia in term and late preterm infant with hemolytic disease of newborn. تفضلي دكتورة.
Okay, thanks for organizing committee for choosing my research. We'll talk about risk factor and predictors of rebound hyperbilirubinemia in term and late preterm infant with hemolytic disease of newborn. As by American Academy of Pediatrics provide guidelines for when to start phototherapy, but a little guidance is available for when to discontinue phototherapy. And in 1991 review recommended stopping birth hospital phototherapy after 2 consecutive total serum bilirubin level less than 11 milligram per deciliter. Although the appendix to the American Academy of Pediatrics hyperbilirubinemia guideline states that phototherapy may be discontinued when the TSB level falls less than 14 milligram per deciliter, an infant readmitted for phototherapy, but no guidance is provided for when to stop birth hospitalization phototherapy. In contrast, the United Kingdom National Institute of Health and Care Excellence guideline recommend stopping phototherapy more than 3 milligram per deciliter below their treatment threshold, which could be TSB as high as 17.5 milligram per deciliter in a full-term infant. The need of measurement of bilirubin rebound after stopping phototherapy has been addressed previously by many observational studies, and this study including both term and preterm infant, and those with hemolytic and non-hemolytic group. This is what was addressed in 2002 by Dr. Saadi. The rebound percent was minimal. And in 2017 by Chang et al., the rebound was 4.6%. And in 2018 by Al-Hawari et al., the rebound was 24.9%. So this controversy in the previous study is related to the mixing of population with hemolytic and non-hemolytic, and in term and preterm infant. And as we had 42.8% of infants admitted with indirect hyperbilirubinemia found to be hemolytic, so we hypothesized this infant are at high risk, and we choose this group for our research. Our objective to determine the risk factor and predictor of rebound hyperbilirubinemia in a term and late preterm infant with hemolytic disease of newborn. The study area conducted in King Abdullah Medical City in ICU Medina, brought by ethical committee. The study design retrospective medical record review of infant with hyperbilirubinemia required phototherapy according to the AIB guidelines, who were admitted over the 4 years period from 1st of January 2015 to 31 December 2018. Target population, term and late preterm infant, more than or equal 35 weeks with hemolytic disease. Inclusion criteria, sign of hemolysis defined by positive direct agglutinin test, blood group isoimmunization, AB or RH, and drop of hemoglobin level by 2 grams per deciliter within the first 24 hours. Exclusion criteria, preterm infant less than 35 weeks, surgical case, multiple congenital anomaly, direct hyperbilirubinemia, sepsis, and other comorbidity. We define the rebound hyperbilirubinemia as return to the treatment threshold within 72 hours of discontinuation of neonate's first round phototherapy treatment. Sorry. This risk factor has been looked for: gestational age, birth weight, and gender. Birth weight in relation to gestational age, mode of delivery, infant race and ethnicity, ABO, RH incompatibility, G6PD, and risk count, initial hemoglobin and hematocrit level, positive direct agglutinin test, rapid decline of hemoglobin, primary treatment, either by intensive or conventional, duration of phototherapy, exchange transfusion, IVIG, backed RBCs transfusion, TSB at phototherapy initiation, and relative TSB at phototherapy initiation to the American Academy of Pediatric threshold, and also TSB at phototherapy termination and relative to the American Academy of Pediatric threshold, peak TSB level, TSB at 24 hours of phototherapy and bilirubin decline per hour, age of phototherapy initiation and termination, and feeding during phototherapy. Statistical analysis using SPSS software version 22, chi-square Fisher test used for comparison of categorical variable, student test and Winty test for numerical variable, and binary logistic regression used to predict predictor and risk factor using forward wall technique for multivariate analysis. Variable introduced to multivariate analysis include those with p-value less than 0.1 by univariate analysis and other relevant variable, and accuracy of the TSB, accuracy of the TSB by ROC curve. Okay, the total admission in the 4 years was 10,751. Admission as neonatal jaundice 1,061. Hemolytic was 455. Excluded 69. 55 was preterm. 4 was direct bilirubin, and 4 missed data, and 6 discharge against medical advice. So included infant 386, divided 2 group, rebound 44, and non-rebound 342. This is cohort characteristic, showing comparison between 2 group, rebound and non-rebound. This is regarding gestational age, birth weight, and the birth weight relation to gestational age in male and mode of delivery. It was not significant. And also this risk factor, all it was not significant between both group. And also treatment and duration of phototherapy, IVIG, also not significant. Here, TSB at phototherapy termination, it was significant for the rebound group, less than 0.001. And relative TSB at phototherapy termination also was significant, less than 0.001. And the big TSB level also was significant. Then table 2, risk factor for rebound hyperbilirubinemia by univariant and multivariant analysis. The same risk factor introduced in this analysis. By univariant analysis, we found the significant was TSB at phototherapy termination and relative TSB to the phototherapy termination. And by multivariant analysis, the single independent factor which was significant is relative TSB at phototherapy termination. So the risk table 3, risk factor for rebound based on the relative TSB divided to 6 group. And we found the significant was the first 2 group, less than 50 millimole from the American Academy of Pediatric threshold. It was significant. And the other group, 50 to 100, also it was significant for rebound. And from 200 to 250, it was significant for the other side with no risk of rebound. Then we measured the accuracy of the relative TSB at phototherapy termination by the ROC curve, and we found the 100% sensitivity, it was 190 micromole. The area under the curve was 77%. So our strength, it is the first study done on infant with hemolytic disease, large sample size. Almost all data were available, only 1% missed data. Limitation, retrospective study, and the level of discontinuation was not controlled. It was physician decision. So in conclusion, relative TSB at phototherapy termination is the single most important independent predictor reported in infant with hyperbilirubinemia secondary to hemolysis, and relative TSB difference of more than 190 micromole per liter less than American Academy of Pediatric threshold appear to be the safest level of discontinuation to decrease the risk of rebound. So
thank you, Doctora. That's it?
So the recommendation for the RCT to validate the safe discontinuation level, which already started in our NICU.
Very good.
And special thanks to my supervisor, Dr. Nihad and Dr. Islam, Dr. Khalid Siri, Dr. Aziza, and medical record team, and Sister Rehab. Thank you.
Shukran, Doctor. Questions from the audience, please. Dr. Kailan.
Can you elaborate further on the relative TSP of discontinuing the phototherapy? Did you look at the value or the relative value to the indicated phototherapy level for that particular baby?
Relative TSP to the American Academy of Pediatric threshold, as we subtract the level which we stop of phototherapy at that level from the American Academy of Pediatric according to the chart.
Okay. Any other questions? Any other question, or we move to the next one? Actually, the next one will be, okay, thank you, Doctor. Thank you. We'll go to the number 6 presentation, and it will be by Dr. Abdel Fattah Mujahid. Welcome, Dr. Abdel Fattah. He will talk about the pulse oximetry screening for critical congenital heart disease at high altitude. Yeah, Dr. Mujahid. We'll give you 8 minutes. Go ahead. Presentation here.
Many thanks for scientific committee to give me this chance to present our research, and also many thanks for audience for this their patience to be still up till now.
It's not working?
Not open.
But it's okay there. This one.
Yes, okay.
This one.
We'll talk today about a very familiar topic. This one, our familiar topic every day, we are dealing with this one. One of our daily practice is pulse oximetry screening for critical congenital heart disease at high altitude. This we are cohorting prospectively at high altitude. This introduction, this one is the last Cochrane meta-analysis done, including 21 study and involving nearly 500,000 participants. The authors conclude that pulse oximetry screening is a highly specific and moderately sensitive test with very low false positive rate. And this current evidence supports the introduction of routine CSHD screening by pulse oximetry. This is one of the earliest and largest studies done, the Sweden study, including 40,000 baby. And this, as you see here, this nearly 100% specific and false positive only 0.17. One of the very most important limitation of this study is that all units included in this study was at low altitude, from 4 meters to 194 meters. And even the authors conclude at the end, as this one, we don't know this about, they recommend finally 95% as a cutoff value pre and postductal saturation for positive screening test. But they don't know if this, they run this same study at high altitude, what will be the figures. They don't know. Even the American Academy of Pediatrics, when they studied this routine screening at USA since 2010 and 11, and they clearly state this algorithm cutoffs may need to be adjusted in high altitude nurseries. But this question unfortunately adjusted to what? To what level? 95, 94, 93, nobody now up till now up to date. We didn't find any evidence in the literature supporting any numbers. And we took this challenge, and this was already our research question. Our objective to identify the cutoff value for saturation at high altitude. Our method started our nice hospital at Abha Maternity. This 2,200 meters above sea level. We measured already exactly by Garmin GPS. Study population, we include cohort, prospectively cohort our babies delivered in AMCH, and we include all babies in ICU admission or prenatally diagnosed as critical congenital heart disease. Our method we are doing usually is our MOH protocol for CHD screening with this focus on 4 things. Number 1 should be done after 24 hours to minimize the false positive rates due to early screening. Number 2 should be done our trained nurse. Number 3, using mathematics with signal extraction technology technique. Number 4, with the same software we have been blocked to be static throughout the study period. And all babies failed exposed to echo before discharge. This already, of course, our research has been approved by our ethical and research committee. We use this IBM SPSS version 24, and for statistical parameters, we use the chi-square test and the Spearman correlation and the Blond-Altman blot. And our cutoff for significant p-value was less than 0.05. Let me share with you our result is our baby flow all over this one cohorting from January 1st, 2017 up to November 13, 2018. We started with 14,530 babies. After exclusion of babies admitted in ICU, and another exclusion has been done before, some babies have not been screened by our nurse, and another exclusion has been done before some babies screened before 24 hours. And our total babies enrolled our study 10,192 patients. Of them came results screen, positive screen 177 patients. Of them only 5 patients came confirmed by echocardiography as having critical congenital heart disease with false positive rate 172. As you see here, this one our false positive rate is 1.7%, but when compared with the Sweden study, which has been done at 194 meters above sea level, it came nearly tenfold, so huge false positive rate. As you see here, this one, by the way, this was not surprising to us, because we have learned from the literature before starting our study that high altitude is complicated by high false positive rate, CCH screening. But what was surprising us, this next slide. We found this mean pre and post ductal saturation 93 and 93, and with no significant difference, as you see here, between pre and post ductal. And even sperm correlation test was very significant, and p-value 0.001. Also, again, means there is no significant difference between pre and post ductal saturation. At that time, with this sweet challenge with our expert statistician, it is one who make it our statistics twice. First time, we make it as 95% as a cutoff value. And then we make it as 93% as a cutoff value. Let us share with me this our tables now. See, first, when we consider 95% as a cutoff value, specificity, for example, it was 98.3. And when you consider finally 93% as a cutoff value pre and post ductal, it reached nearly 100%. And look also on positive likelihood ratio, when you consider 95% as a cutoff value at high altitude, it came only 32.8, which jumped to 169, very significant, when we consider pre and post ductal 93%. And also negative risk jumped from 70 and shoot to 329 when we consider the cutoff value was 93 pre and post ductal saturation. Let us see where we are in relation to other studies. We found only very, very few studies all over the world talking about these numbers. This one of this study, Samuel and his colleagues, they compare 119 patients at mild altitude only, at 780 meters, with 80 patients at sea level. They measured the pre and post ductal saturation at 24 hours and 72 hours. And what they found all babies less than 95% was completely normal, confirmed by normal echocardiography. And this they found what they considered 95% as a cutoff value, this increased the false positive rate 3.5 times. As they conclude lastly that saturation is approximately 0.4% at lower altitude, at moderate altitude at 780 meters compared with sea level. This is the second study done in Colorado, 2013. This was looking at feasibility of critical CCHD screening at moderate altitude only. They include 2,003 babies enrolled, no cardiography done for these patients, and second high failure rate was 1.1%. And they conclude implementing this CC screening as moderate altitude is feasible, but increase the economic, emotional, and logistical burden on families, communities, and health resources. And this, of course, because of high false positive rate, which you need parental counseling and echo appointment and so on. And they recommend, finally, the larger study should be done with alternative algorithm are warranted at moderate altitude. Our study is considered the first and largest study up to date to concentrate on the cutoff target value for CCH screening. We conclude firstly, our study supported the American Academy of Pediatrics recommendation suggesting algorithm cutoffs may need to be adjusted in high altitude. Number two, cutoff points less than 93% at high altitude showed specificity 98.3%. And if considered the pre and post ductal, specificity approached almost 100%. Number three, our study showed this saturation is approximately 0.9% lower for every 1,000 meters above sea level. Our study finally raised the urgency for a registry for saturation at different altitude to make a final conclusion about cutoff saturation values at which saturation screening test to be considered positive. We cannot forget to acknowledge our NICU staff and cardiology staff and the screening program nurses and Dr. Faisal Farhat, our expert statistician, and also special thank you for Sister Zara. Sister Zara was the head nurse of the screener nurse sisters, and she did very good job with that. Unfortunately, a few months back, we have lost her in a motor car accident. And while we are talking about this study, we cannot forget her. Thank you.
Thank you, Dr. Mujahid. Yalla, questions?
Thank you very much for this amazing study. Just one thing, when you say, what is it, false positive, my worry is that not only the congenital heart disease, my worry is about pneumonia, sepsis, and so on. So in your area, maybe or some other areas, they have limited resources. So what's your comment about the false positive? Are they really truly false positive? They have nothing else apart from...
Yeah, sure, because this was, as I mentioned now, this was, there's one slide for population we didn't see. We didn't, all babies less than 34 weeks admitted with ICU, and all babies, this was in well baby and nursery. All babies was completely normal, as regards. So the all babies, like before discharge examined, it was completely normal. As regards this issue, other causes, you mean Dr. Zakaria, is completely normal.
Okay, next question.
What's the design of your study?
Yes, this is prospective cohort study.
Huh?
Cohort prospective study.
Cohort prospective?
Start from one
do you have a protocol that's done by the, and then you collected the data from the charts or what?
Yes, we started from January 17.
So you have a protocol that's implemented in your unit?
Yeah.
And then you went back and you collected all the data, right?
Yes, sure.
Okay, thank you.
Okay, any other question? Quick one for Dr. Mujahid. Okay, I would like to thank you, Dr. Mujahid.
Thank you.
And thank for all the presenters for sharing with us their work. And we are waiting for the judge to give us the result. There will be 3 winners. So you need to wait to know who's the winners. And before you know the winners, we have a small part of our program for which we want you. We want Dr. Ibrahim Al-Hifzi to come on the stage. We want to recognize the companies that they participate with us and, like, helping, Can Dr. Kailani, okay. Dr. Hifzi, please. Okay, so we want the companies, representative to come to the stage as we call their names. طيب okay. دكتورة, you go down. The golden sponsor, ABV. For the time's sake, the golden sponsor, Nutricia. For silver, sponsors Nestle, also Nutricia, but they like to be called Nestle. Yeah, come in. Okay. This is a silver sponsor. Silver sponsor, Bremilag. Bronze sponsor, Medtronic. Another bronze sponsor, Abbott. Abbott. Then Draeger. Draeger as a bronze sponsor. Draeger, are they here? Yep. Come. You need to be golden next time, huh? Or platinum, huh? طيب اوكي. طيب انا داري. Bronze, white, nutrition. Bronze, الجيل. Of course, we highly evaluate all the sponsoring of our work. الجيل. Another bronze sponsor, Roneska. Nutrition for life. You should concentrate on older people, huh? Then, Roneska. Bye. Bronze sponsor, Ordisa.
شكرا.
هلا الله يحييك. حياك الله بس. Bronze sponsor, Techno Orbit. Techno Orbit. So in the name of the Society of Saudi Neonatology, we would like to thank them all, and we evaluate high their participation and supporting the meeting, and we hope for the best for the society and the next meeting. As we are coming for, yeah, he's busy. He's busy. We are waiting for the awards and the 3 winners from the abstracts, and it's coming soon. Meanwhile, I would like to remind you to be a member of the society. You need to be a member of the society. And now, because Ramadan is coming, we have a special offer. And the special offer, if you become a member today, for 3 years, only 300 riyal, and we'll give you valuable gifts from Intercontinental as a coupon for discount for your iftar or sahur during Ramadan. So welcome. Do it today, huh? The one who did the membership, he can do again, and we'll give him that one. It's okay. Okay, the result. Meanwhile, while we are waiting for the result, don't forget, we come out from this room, we have workshops. We will end our meeting with 2 workshops, respiratory and skincare. So don't miss, both are important topics and you need to attend. And hopefully you will carry all of you nice memories from this meeting, the 19th annual society meeting. Next year. What about next year? Next year we have a plan, and the plan, inshallah, it will be consolidated, and of course you will have an announcement, but we are aiming for the south, and in particular to Abha, inshallah. The research and the young, investigator, please come forward and repeat this experience with us, and encourage your colleague to come forward and
and participate. I think important piece of this meeting, the annual meeting, is to have you come forward and present your work and see the reaction of your colleague to it, and we learn from each other. Definitely.
Those people who complain from the lunch today will bring it to the highest level of this hotel. Intercontinental, we will really put them under investigation because really they didn't treat you well during the lunch today. And I apologize in the name of the organizing committee for that. Okay? And the one who is really not feeling satisfied, we'll give him a coupon for that. Go to Shino. Go to Shino, huh? Give them a coupon.
They are cooking the result.
Go ahead. Apparently the competition is high and we're having difficulty to find the winner. But I found Dr. Alayan and Dr. Kailani working hard. So I will tell you about the prizes. Actually, we have three levels. Number one, winner will take 5,000 riyal. Inshallah, yalla. Should help. But you need to present first. The second winner will be receiving 3,000, and the third will receive 2,000 riyal.
This time we got 33 abstract submissions.
Okay, the total submission this year was 33 abstract. So we choose out of them 6 to be presented. So inshallah with the years will come, we'll have more abstract, presented. More money, but also we need more work, and I think our colleague, they can do it, and hopefully we can give even more than one session for research.
More participation for the application for the research
I think this is important. Dr. Jabara, she's the scientific committee chair, and she said most of the participation comes from the western area of the country. So the middle and the eastern, and the middle and the eastern area, they should work harder. I know the eastern province usually they have a lot of presentation, but I don't know what happened to them this year. Okay, so the result is there. They will announce it, and the one who will hear his name will start by the first one or by the third. People waiting for your answers.
The form this year is too long and very extensive. This is why it took us too long. We haven't really calculated the time. Now we get to all the evaluation from everybody.
You can repeat with the muazzin while they are doing the exam. حي على الفلاح. Those of you who are traveling tonight, we wish them safe travel and arrival to their family, and we'd like to thank them for being with us here in the last few days. And inshallah, the impression is as we expect, inshallah. And don't forget the evaluation and the website. Please do the evaluation because that will be important for us. The evaluation on the website, and if you fill the evaluation, you will automatically have your certificate of attendance.
which is not equal to the CMA. CMA hour, we will enter it from the society. And you should receive it in the next 1 or 2 weeks. Okay?
This year, as you know, the conference is 3 days, and every year since we start, it's 2 days, and the third day is a workshop. So we'd like your opinion in that. We need to continue or going back to the previous, 2 days conference and the last day workshop. So you can practice the evaluation, just to know for the next conference, inshallah.
We are ready. Excellent. Go ahead. Now, come both, please. Even Dr. Kailani. Come in, please. So, yeah. You are the one who also with Dr. Hafdi will give, the gift. هذولك ملحق يا طويل العمر. نواف هذولك الملحق.
ضحك دكتور. overall comments
very difficult.
تفضل صالح.
هنا اقدمها هنا.
You can do it here.
Okay.
Just I want to make a comment first. This is really elating to have these studies conducted in our region. So I encourage you and support you. This is really excellent work. Overall comment, just general. Try to define your aim more specifically. That will help you make better calculation for the numbers that are required once you have an aim defined clearly, and that will allow you to really do better calculation for the power. That will empower your study, because we probably underscored some because of that reason. In general, thank you.
Thank you. Yeah, I wanted just to tell you that we did the evaluation of the scoring independently. We didn't really cheat from each other. And we came exactly the same. I mean, like the first and second and the third.
Too good to be true.
So you have to trust us. If you don't, it's not my problem. Okay, the first one, the third one, who scored 72.5%, Dr. Shadi Nu'man. I have to give it to him. لا لا.
العافية شيخ. ورا لهم تحت إن شاء الله. والبارتيسيبيت إن شاء الله.
Good. The second one, who scored 80.5%, Farzeen Muhtashim.
And a quick comment for Farzeen. You could have had really 95% if you change the design, because the design has to be mechanistically sound. When you give date, you don't expect the effect to continue for 48 hours. So the effect should be within just 2 hours. If you limit your hypoglycemia within that range, maybe you will see a difference even. Because mechanistically it doesn't make any sense to follow glucose 48 hours. But review the data and see what effect it has just in the first 2 hours.
Good. The first one, who scored 87.5%, is Dr. Jamal Atiyah.
Again, for the delayed cord clamping, be specific about the outcome of IVH, because that would be the main concern. With cord milking, the IVH is still a concern, and probably the calculation should have been done that way.
Yeah, just there is a presentation. So, sorry. Okay, there's something for you, Dr. Ramzi.
Dr. Ramzi.
What about this?
Dr. Ramzi, thank you for participation.
Go and collect if you don't mind.
Group picture. Anybody want
دكتور شنو يلا تعال شنو اخر هذا شنو
مش مشكلة
جروب بيكتشر عشان يسمعوا